Here we are looking at the side view of the baby and showing the foregut, midgut and the hindgut. You can notice the midgut is sending one diverticulum which is called as the vitellointestinal duct, which will become a content of the umbilical cord. Let me zoom that area now. So here we see that is the umbilical cord here, and which is containing two of the diverticula, one from the midgut and one from the hindgut. The one which comes from the hindgut is called as the allantois, and you can see here it is attaching to the apex of the urinary bladder. Urinary bladder and the urethra, they develop from urogenital sinus, which is in the terminal part of the hindgut cloaca region, and the apex of the urinary bladder is having a process or the hindgut diverticulum, the allantois, which is going to become a content of the umbilical cord. Normally these two diverticula are obliterated, otherwise there might be problems like a baby born with the urine at the umbilicus, and that is called as urachal fistula, which we need to discuss, or another baby born with fecal matter at the umbilicus, and that is called as the Meckel fistula, and that is a terminal ileum sending fecal matter towards the umbilicus region on the anterior abdominal wall. So let us look at both of these cases now. As we are looking at the side view of a developing baby, let us magnify the contents of the umbilical cord there, and as we understand, it is the yolk sac which is going to form the gut tube, which is having the foregut, the midgut and the hindgut region. And in the midgut there is a diverticulum which is called vitellointestinal duct passing through the umbilical cord and is in communication with the yolk sac there. Normally it must be obliterated, but if it is not obliterated, then it can form Meckel's anomalies. Let us have some details of that now. As you can see, this is the yolk sac which was communicating with the midgut with the help of vitellointestinal duct, which normally must be obliterated, but in some people it might be persisting, and let us look at that anomaly now. Here it is called as the Meckel's diverticulum, attaching to terminal part of the ileum, which is the midgut portion, and it is having some fibrous attachment with the umbilicus on the anterior abdominal wall. Now the mesentery is attaching to posterior abdominal wall, and this is on the anti-mesentery border. It can happen that it may be having a patent lumen and some fecal matter coming to the umbilicus, and that is a baby born with fecal matter at the umbilicus is Meckel's fistula. It is a true diverticulum as it will have all the layers of the gut tube, may it be the mucosa, submucosa or muscular externa or serosa. And since it is a midgut diverticulum, the referred pain will be felt at the periumbilical region. Now let us talk about the allantois also, which is a hindgut diverticulum, and it is also going to become a content of the umbilical cord, surrounded by two umbilical arteries and two umbilical veins, but later right umbilical vein will regress and left umbilical vein will be left. Normally this allantois becomes fibrous called as urachus in the adult, and it has no patency of lumen. But in this case we see that the urachus has the patency of lumen and is bringing the urine from the apex of the urinary bladder towards the umbilicus region. So a baby born with urine at the umbilicus, it is the persistence of the lumen in the urachus, and this is called urachal fistula. Now here again we look at the umbilicus on the anterior abdominal wall, and the content of the umbilical cord, which we can see are the urinary bladder apex having the attachment of the allantois in the fetal stage, and in the adult it would have become urachus, and it is a content of the umbilical cord as such. It forms a median umbilical ligament in the adult, and it is covered by a peritoneal fold in the midline anterior abdominal wall with the umbilicus, and that is called as median umbilical fold. The fold is a peritoneal covering over the ligament, which itself is called median umbilical ligament. Then there are two medial umbilical ligaments also, which are formed by the umbilical arteries, which are the content of the umbilical cord. Normally these umbilical arteries must be obliterated to form the medial umbilical ligament covered by some peritoneal fold called medial umbilical fold. These are all structures in the lower abdominal wall, and you will find the umbilical arteries are running towards the umbilicus, have been obliterated and forming medial umbilical ligament covered by some peritoneal fold called medial umbilical fold. But the proximal part of the umbilical artery will be persisting in the adult, and they form the superior vesical artery, and that will continue supplying the urinary bladder in the adult. Here is the left umbilical vein, which is running towards the lever and is carried by a double fold of the peritoneum called as the falciform ligament of lever. Later, the left umbilical vein will become ligamentum teres, and it will also be a content of the falciform ligament of lever. This is the terminal ileum showing the Meckel's anomaly here. Normally, the vital intestinal duct must be obliterated. If it is not obliterated, then it can form Meckel's anomalies. Let us now take a transverse section of the umbilical cord. And you see it is covered by the amnion here. Inside is a jelly which is called as the Watten's jelly. And then we got the remnants of the vital intestinal duct, the midgut diverticulum, and remnants of the allantois, which is the hindgut diverticulum. And along with that, there are two umbilical arteries which are shown in blue color because they have less of oxygen, deoxygenated blood. And then this is left umbilical vein, which is shown in red color because it is having high concentration of the oxygen coming from the mother, the placenta, towards the baby. Only the left umbilical vein is left and the right is regressing. Now, wherever the right was regressing, there was a weak spot created and some intestine has herniated from there outside the umbilical cord. And that is called as gastroschisis. Gastroschisis is intestinal herniation at a weak spot created by the regressing right umbilical vein. And intestine comes out of the umbilical cord. Umbilical cord will be normal, and this intestine is outside the amnion. It is not covered by amnion since it came outside the umbilical cord. Let us look at the baby having such an anomaly now. As you can notice, this is the intestine which has come outside the abdominal cavity. It is outside the umbilical cord, and this is a normal umbilical cord. This gastroschisis is not covered by any amnion here, and it is seen on the right side of the umbilical opening. Let us compare it with omphalocele then. It is to be understood that there is part of the midgut which will be herniating inside the umbilical cord at week number 6. That is called physiological umbilical hernia. What happens is that the gut is growing very fast and the abdominal cavity is small. It is not large enough to accommodate the fast growing gut tube. So part of the gut tube, that is midgut, will enter the umbilical cord temporarily, and that will be happening at week number 6. At week number 10, it will regress back when the abdominal cavity is large enough. In some cases, it may not be coming back, and it will be seen a baby born with the midgut content inside the umbilical cord called as omphalocele. So omphalocele is non-regression of the physiological umbilical hernia, and the content will be inside the umbilical cord covered by the amnion. As you can see, omphalocele. Omphalo is umbilicus, cele is a hernia. You see some part of the intestine has entered the umbilical cord, and it is lined by the amnion. Normally, this will go back by 10th week of development, but if it does not go back, it stays inside the umbilical cord, then we'll call it as omphalocele. Let us look at a baby having the same problem now. Here you can notice that this is the lever along with the intestine inside the umbilical cord, and it is lined by the amnion. It is a midline problem as compared with gastroschisis. Let us compare it with gastroschisis then. Understand, gastroschisis is intestinal herniation on the right side of umbilicus, but this is intestinal herniation along with the lever in the midline. These contents are covered by amnion since they are inside the umbilical cord, but here the intestine is not covered by amnion since it has come outside the umbilical cord. Umbilical cord is normal here. These babies, when we operate upon them and send the intestine back, we will find they have a long mesentery, so there is always a chance of volvulus and obstruction. Whereas these babies are dead babies since they are having multiple congenital anomalies that could be chromosomal defect, neural tube defect, cardiovascular defect that will kill the baby. Talking about the development of diaphragm, we have a partition which is a thoraco-abdominal partition called as septum transversum. Septum transversum is going to form the central tenon of the diaphragm, and along with that there will be some pleuroperitoneal membrane, one on each side contributing to the diaphragm, which is going to separate the thoracic organs from the abdominal viscera. In the thorax you will have the heart and the lungs, and in the abdomen you have the liver and the rest of the GI tract and genitourinary tube as well. Now looking at the septum transversum from the front view, this is also called as pericardio-peritoneal membrane because it is separating pericardial cavity from the peritoneal cavity. Then you have the pleural cavity on either side, which are separated from the peritoneal cavity by pleuro-peritoneal membrane, one on the right side, one on the left side. They'll be fusing with the septum transversum, contributing to the diaphragm. Diaphragm is going to have 4 embryological contribution, and 2 of them we have seen. Now the third one is the body wall on either side, and fourth component will be the dorsal mesoesophagus, the dorsal mesentery of esophagus, which will be lying posteriorly and contributing to the crura of the diaphragm. Can be seen in transverse view of the developing diaphragm. Sometime it may happen there is a deficiency in the left pleuroperitoneal membrane and it is a congenital diaphragmatic hernia and leading to abdominal content into the left chest cavity called as the Bochdelic hernia. We'll be looking at such a baby in a short while. But here we want to look at the inferior view of the developing diaphragm, like you have taken a CT scan and you are viewing from below inferior to superior. You are in the abdomen region looking towards the thorax region. So here is the inferior view of the developing diaphragm, and you can see that more anteriorly is the septum transversum forming central tendon of the diaphragm. Then you have the pleuroperitoneal membrane, which will come posterior-medially and fuse with each other, forming some component of the diaphragm. And then there is a contribution from the dorsal mesentery of esophagus, forming the crura of the diaphragm. There is a right crust, left crust of the diaphragm attaching to the lumbar vertebra posteriorly in the abdomen region. You can also see that there is the body wall contributing to the peripheral diaphragm, which will be later invaded by the muscles coming from the cervical region. Cervical myotome, cervical root value is 3, 4, 5. Hence, the phrenic nerve, which is following the diaphragm here, is also cervical 3, 4, 5 root value. So, diaphragm is basically a skeletal muscle controlled by a somatic nerve called as the phrenic nerve. You can also see some openings here in the diaphragm. Inferior vena cava is passing through the central tendon of diaphragm at the T8 vertebral level. It is a tendinous opening. Esophagus is passing through the muscular opening in the diaphragm at T10 vertebral level. And aorta is passing behind the diaphragm. It is an osteoaponeurotic opening in front of the T12 vertebra. Sometimes there is a deficiency in the left pleuroperitoneal membrane leading to Bochdelic hernia. Let us discuss that case as well. Here is a case of congenital diaphragmatic hernia, which is most commonly the Bochdelic hernia, deficiency in the diaphragm here due to deficiency in the left pleuroperitoneal membrane, leading to some of the abdominal viscera into the left chest cavity, which are the spleen, as you can see, entering the left chest cavity. Also, the intestine and stomach may also be herniating into the left chest cavity, leading to left lung hyperplasia. Plus, since there are abdominal viscera in the left chest cavity, they push the heart towards the right side. There is a right mediastinal shift compressing the right lung also. Now, the right lung is compressed and the left lung is showing hypoplasia. Obviously, this baby, as it is born, will be having respiratory distress at birth and it is a neonatal emergency. Talking about the 3 openings in the diaphragm for the passage of various tubes, you can see at the level of the T8 vertebra, there is a tendinous opening for the passage of inferior vena cava to enter right atrium of the heart. At the T10 vertebra level, there is opening for the esophagus, which is a muscular opening. In front of the T12 vertebra, there is thoracic aorta passing behind the diaphragm to enter the abdomen, become abdominal aorta. There is an aortic hiatus, which is osteoaponeurotic opening behind the diaphragm. Remember, inferior vena cava and the esophagus are passing through the substance of the diaphragm, whereas the abdominal aorta do not pass through the diaphragm. It is passing posterior to the diaphragm, not within the diaphragm. Now again, we are looking at the inferior view of the diaphragm. You are in the abdomen region, looking towards the thorax region, and you can find lumbar vertebra 1 to 3. Attaching to lumbar vertebra 1 to 3 is the right crus of diaphragm, and attaching to L1-2 is the left crus of diaphragm. So left is shorter, the right is longer. They are united by a median arcuate ligament running in front of the T12 vertebra, making aortic hiatus. Hence becomes osteoaponeurotic opening for the passage of the abdominal aorta. Along with that is passing thoracic duct also in the aortic hiatus. Though the azygous vein is piercing the right crus of diaphragm to enter the thorax, sometime it may be found inside the aortic hiatus. In that case, the thoracic duct will be sandwiched between vein on the right side and aorta on the left side. Usually, the azygous vein will puncture the right crus of diaphragm to enter the thorax, and hemizygous vein will puncture the left crus of the diaphragm to enter the thorax. These crura are also punctured by the greater splenic nerve, lesser splenic nerve, which are coming from the thoracic sympathetic chain and entering the abdominal region to supply the abdominal viscera. You can notice that right crus is sending submuscular fiber around the esophagus, which is passing through the diaphragm at the T10 vertebral level along with the right and left vagus. The right vagus vagus goes posterior and left vagus come anterior. So there is an anterior posterior vagal trunk. Along with that, there will be some few branches of the left gastric vessels supplying lower one-third of the esophagus, the abdominal esophagus, passing through the muscular fibers of the right crus of the diaphragm. And at the T8 vertebral level, there is a passage of the inferior vena cava. Along with that come few branches of the right phrenic nerve at the central tenon of the diaphragm there. Sometimes there can be a left posterolateral opening in the diaphragm, which is Bochdelic foramen and leading to Bochdelic hernia, deficiency of left pleuroperitoneal membrane, or sometimes there can be Morgagni hernia, which is usually right anterior and medial as compared with left posterolateral Bochdelic hernia. Morgagni hernia is leading to transverse colon from the abdomen to enter the thorax, reach in front of the heart, and behind the bone sternum, showing some gas shadows in the anterior mediastinum. Morgagni hernia is rare type, whereas Bochdelic hernia is the most common type of congenital diaphragmatic hernia. Now, let us talk about the development of the mesentery, which is a double fold of peritoneum to carry the neurovascular bundle towards the various abdominal viscera. Here you are looking at the buttocks region, and it is the transverse section of the abdomen region, showing the lumbar vertebra. In front of that is abdominal aorta, sending some branches to supply the gut tube, and those branches are carried by the mesentery. The gut is covered by the visceral peritoneum and is reflecting onto the body wall, which is then called as the parietal peritoneum. Between the parietal peritoneum in the periphery and the visceral peritoneum on the viscera, there is a space, and that space is called as peritoneal cavity, which is large in the beginning but later become very small since the abdominal viscera become more and more crowded in the cavity. Now, this gut tube is the axis which will decide whether it is a dorsal mesentery or ventral mesentery. If it is attaching to posterior abdominal wall, then it will be called as posterior mesentery or dorsal mesentery. If it is attaching to anterior abdominal wall, then it will be called as the ventral mesentery or anterior mesentery. And depending upon which viscera it is attaching, the names are given. It may be called as mesoenteron if it is attaching to small intestine. It is mesocolon if it is attaching to colon, or it could be mesoesophagus, it could be mesoduodenum, it could be mesoappendix, etc. Let us look at a side view of the mesentery then. Here you can see this is the esophagus, which is going to become stomach, is going to become the duodenum, and all the three are covered by a double fold of peritoneum coming from anterior abdominal wall to the posterior abdominal wall. This double fold of peritoneum is bringing some blood vessels and split to enclose these viscera and go to the posterior abdominal wall, then run on the lateral abdominal wall and again come back to the anterior abdominal wall and again repeat the same process there. Later we'll find the liver is developing in the ventral mesentery and the spleen is developing in the dorsal mesentery. There will be some ligaments of the spleen and ligaments of the liver which we need to discuss. But before that, you can see that on the posterior abdominal wall you have the abdominal aorta supplying the gut tube, the celiac artery to supply the foregut derivative, the superior mesenteric artery supplying the midgut derivative, and the inferior mesenteric artery supplying the hindgut derivative. You can notice that superior mesenteric artery is coming out of the anterior abdominal wall through the umbilical opening to enter the umbilical cord. And why is that happening? Because the midgut itself is entering the umbilical cord. As we suggested, it is called physiological umbilical hernia, occurring at week number 6 and should be regressing at week number 10. If it does not regress, then there will be omphalocele. Now, as we are suggesting, this superior mesenteric artery, the artery of the midgut, is going to become axis on which the midgut is going to rotate anti-clockwise by 270 degree, which we'll be seeing shortly. But at this moment, you can see the liver has come in the ventral mesentery and spleen has appeared in the dorsal mesentery. Spleen developed from the mesoderm of the dorsal mesentery, whereas liver developed from the endoderm of the foregut. And you can see in the next diagram the developing pancreas as well. Now, when it comes to pancreas, most of it is developing in the dorsal mesentery, though partly it is developing in the ventral mesentery. A part of the head of pancreas and the uncinate process develop in the ventral mesentery, but later they migrate to the dorsal side and become a content of the dorsal mesentery, can be seen in the next diagram. At present, you can see this is the umbilical opening on the anterior abdominal wall and letting pass the left umbilical vein, which is coming from placenta and entering the liver. To reach the liver, it is passing through a double fold of peritoneum, which is called as the falciform ligament of liver, developing in the dorsal mesentery. In the dorsal mesentery also develop the coronary ligament of liver, which will be connecting liver superiorly to the diaphragm. And there is one more liver ligament here, which is called lesser omentum, attaching to the lesser curvature of the stomach, which is anteriorly in the beginning. In the beginning, lesser curvature is anterior and the greater curvature is posterior, but later the stomach will be rotating to assume the adult position. We'll talk about stomach rotation in a short while. while. At this moment, we are looking at three ligaments, which are the lesser omentum and the coronary ligament of lever and the falciform ligament of lever, developing in the ventral mesentery. Remember, this ventral mesentery itself is coming from the septum transversum, which is going to form the central tendon of diaphragm as well. Central tendon of diaphragm develop from the septum transversum, and septum transversum also form the ventral mesentery of the lever, and hence these three ligaments of lever are derived from septum transversum indirectly. This lesser omentum is attaching to porta hepatis of lever, and the lesser curvature of the stomach is having two parts. One part is called as the hepatogastric ligament attaching to lesser curvature of stomach, and the other part is called hepatoduodenal ligament attaching to the first part of the duodenum, and it is the hepatoduodenal ligament part of the lesser omentum containing the DAV structure. D for duct, the bile duct, A for artery, the hepatic artery, and V for the vein, portal vein. We'll talk about the DAV structures once again. At this moment, just remember, falciform ligament develop ventral in the ventral mesentery, and the lesser omentum develop dorsal in the ventral mesentery. Let us look at the dorsal mesentery as well, and the ligaments developing there. Spleen will be having one ligament with the greater curvature of the stomach, and it is called as splenogastric ligament, and will have one ligament posteriorly which is related with the kidney, and that will be called as splenorenal ligament. Actually, kidney was developing in the pelvis and later ascend up into the abdomen to reach behind the spleen, and then have the ligament called splenorenal ligament. Abdominal aorta, which is lying on the posterior abdominal wall, will be giving the splenic artery to spleen, and that splenic artery will be carried by the splenorenal ligament, and the splenic artery giving some branches to the greater curvature of stomach, that is short gastric arteries, will be then carried by the splenogastric ligament. Now let us look at the developing diaphragm as well. As I suggested, the part of the head and the uncinate process develop in the ventral mesentery and later will be migrating to the dorsal mesentery. Most of the pancreas develop in the dorsal mesentery, and we will see that there is dorsal pancreatic bud which will form distal part of the pancreatic duct. You can remember DD, dorsal pancreatic duct, for the distal part of the pancreatic duct. Now let us look at the next diagram. As we can see, the ventral pancreatic bud has moved to the dorsal side, and the DD, that means the dorsal pancreatic bud is forming the distal part of the pancreatic duct, which is the duct of the Wirsung. And while proximal part of the main pancreatic duct of Wirsung is contributed by the ventral pancreatic bud. And here you can see the accessory pancreatic duct of Santorini as well. The lower head of pancreas and the uncinate process of pancreas come from the ventral pancreatic bud, whereas rest of the pancreas is from dorsal pancreatic bud, which includes the upper head, neck, body, and the tail of pancreas. There can be cases of annular pancreas when the ventral pancreatic bud is rotating and coming to fuse with the dorsal pancreatic bud. It can be around the second part of the duodenum and compressing the duodenum here, leading to some obstruction. Symptomology. Now let us talk about the details of the gut rotation. As we have suggested, the midgut will be entering the umbilical cord at week number 6, which is called physiological umbilical hernia, followed by superior mesenteric artery, and there begins the gut rotation. Understand that DJ, the duodenojejunal junction, is a high point part of the midgut which will enter the umbilical cord, and the IC ileocecal junction part of the midgut will also enter the umbilical cord, and then they start rotating. If you look from the front, then you'll find the DJ is superior, IC is inferior. They enter the umbilical cord and then they rotate by 90 degrees within the umbilical cord. The DJ, which was superior, is now going to become right-sided, and the IC, which was inferior, is going to become left-sided. So superior and inferior structure become right and left side within the umbilical cord. Then they start coming back into the abdominal cavity and rotate the rest 180 degree anti-clockwise. The DJ, which was right side, will become inferior and to the left side, whereas the IC, which is to the left side, will become superior and to the right side. In fact, there is total 90 degree plus 180 degree, total 270 degree rotation anti-clockwise, which we can see in the next diagram now. The axis of rotation is the superior mesenteric artery, seen from the front view. So here you can see superior mesenteric artery is the axis of rotation, and there is a high point which is the cranial limb or the DJ, and then there is the caudal limb or the IC. In the beginning, they are superior and inferior inside the umbilical cord as they enter. Then they rotate by 90 degree anti-clockwise so that the DJ becomes right-sided and IC become left-sided. Now they start regressing back into the abdominal cavity. And while doing that, they are rotating another 90 plus another 90 degree rotation. Total 270 degree anti-clockwise rotation. So here, as we start, the DJ is on the right side. It will come inferior and then it comes to the left side. Whereas the IC, which was on the left side, goes superior and comes to the right side. And after rotation is completed, the ileocecal junction, which is on the right side, is going to descend down into right right iliac fossa due to some differential growth. And after that, the colon will have four parts, which are called as ascending colon, transverse colon, descending colon, and the sigmoid colon. Understand that small intestine came back early and large intestine came back later. So large intestine is in front of the small intestine. In fact, transverse colon is passing in front of the second part of the duodenum. As the large intestine came back later, it was found more anterior, though it can reverse also, which is called reverse rotation, and in that case, you will have to correct it and bring the transverse colon in front of the duodenum. That will be your operative procedure in reverse rotation. Now understand that colon is at the periphery and small intestine is at the center. This is normal. And after rotation, colon has four parts and so is the duodenum, which is lying behind the colon. Now let us look at some rotation anomalies. Sometimes there can be an anomaly called non-rotation, where you'll find that small intestine is on the right side, the DJ is on the right side, and large intestine is on the left side, the colon is on the left side, IC is on the left side. What happened here was, when DJ and IC went inside the umbilical cord and rotated 90 degree, after that they did not rotate the further 180 degree. So the DJ or small intestine is on the right side and the IC or large intestine is on the left side. As you can see here, the intestine came back without any further rotation. That is called as non-rotation. Similarly, there can be other problems which go into the territory of surgical description. But let me just briefly tell you, there could be cases of mixed rotation, which is also called as incomplete rotation. You'll find there are some lad bands which are abnormal peritoneal adhesions and holding the cecum below the pylorus of the stomach in the midline. The cecum is missing from the right iliac fossa, which is the normal position in an adult. It is actually found fixed in the midline below the pylorus of stomach. And if we are talking about the reverse rotation, the rotation is clockwise and the large intestine came back early. So it is the transverse colon passing behind the duodenum and also behind the superior mesenteric artery, which is compressing the colon. In this case of reverse rotation, you have to bring the colon to safe place, which is in front of this artery and in front of the duodenum. That is your corrective operative procedure. Also understand that in the beginning, small intestine, all of it will have the mesentery, but later the duodenum becomes retroperitoneal. So mesentery will attach only to the jejunum and ileum. There will be a route of mesentery which is running from duodenojejunal junction to the ileocecal junction, and we want to talk about that now. So here is the route of mesentery which is coming from duodenojejunal junction and to the ileocecal junction. It starts from almost in the midline of the body, slightly to the left, and running towards the right iliac fossa, crossing the third horizontal part of the duodenum. This is the C-shaped duodenum after rotation. It has four parts here, and the root of mesentery or the base of mesentery crosses the third horizontal part of the duodenum anteriorly. There is a question asking, root of mesentery crosses which all structure anteriorly? And your answer is third horizontal part of duodenum and the abdominal aorta on the left side of midline, inferior vena cava on the right side of midline. It is also crossing the gonadal vessels and the right ureter as well, and runs in front of the psoas major, but only on the right side. Because it is a right-sided structure, it will cross only the right-sided gonadal vessels, right ureter, and right psoas major. It is where the mesentery will be attaching and spreading towards the jejunum and the ileum, so that here some blood vessels can pass and go supply the jejunum and the ileum, whereas the duodenum becomes retroperitoneal, does not have a mesentery. It has lost it during development. Let us now talk about the neurovascular bundle in the abdomen region. What you are looking at is the abdominal aorta on the posterior abdominal wall, giving the celiac artery to supply the foregut derivative, superior mesenteric artery supplying the midgut derivative, and the inferior mesenteric artery supplying the hindgut derivative. The junction of the foregut and midgut is in the second part of the duodenum, where the liver and pancreas will be developing. The proximal part of the duodenum belongs to foregut, supplied by the branches of celiac trunk, and distal half of the duodenum, which belong to midgut, will be supplied by the branches of superior mesenteric artery. The junction of the midgut and hindgut is on the transverse colon at the junction of right 2/3 of transverse colon and the left 1/3 of transverse colon, which is the splenic flexure, and that is the point till which the superior mesenteric artery will be supplying. Superior mesenteric artery supplied till the right 2/3 of transverse colon along with the vagus nerve. Vagus nerve supplied till the midgut. Then who is supplying the splenic flexure and rectum part of the hindgut? That will be the next set of nerves, and that will be the nervi irrigantes. Nervi irrigantes, along with the branches of inferior mesenteric artery, will be supplying the hindgut. Included is the splenic flexure and the rectum part here. Now you are talking about the parasympathetic system. What about the sympathetic nerve for the hindgut or for the midgut and foregut? Let us find out the details about them as well. But first we are looking at the branches of the abdominal aorta. As you will see, there is aortic hiatus in front of T12 vertebra for the passage of the abdominal aorta, which will be bifurcating into common iliac artery at the L4 vertebra. Common iliac artery are called common because they further divide into two. There is internal iliac artery, external iliac artery. External iliac artery will pass under the inguinal ligament to become femoral artery in the lower limb, whereas internal iliac arteries will be supplying the pelvic viscera, namely urinary bladder, behind that uterus and the rectum, giving branches like the rectal artery, uterine artery, and the vesical artery. But internal iliac artery do not give you the gonadal arteries. Why? Despite the fact that the ovaries are in the pelvis, why ovarian artery are not branches of the internal iliac artery? Because the ovaries or testes, they are already given branches by the abdominal aorta. Now, gonadal arteries are branches of the abdominal aorta. Why? Because gonads develop in the abdomen, later descend down to pelvis, carrying their arteries, and the ovarian artery is shorter as compared with the testicular artery because testicle will move from the pelvis into scrotum as well, making the testicular artery longer than the ovarian artery. Now, the renal arteries, as you see in the adult, are branches of the abdominal aorta, but in the fetal stage, since the kidneys develop in the pelvis, the renal arteries were branches of common iliac artery and median sacral artery. Later, as the kidneys will ascend up into the abdomen, they acquire branches from the abdominal aorta, and the branches of the common iliac artery will be regressing. You can also see the branches to the foregut called as celiac trunk, the midgut called as superior mesenteric artery, and the hindgut called as inferior mesenteric artery. They are anterior branches. Gut tube develop in front of the abdominal aorta in the midline, so the arteries are anterior branches, whereas the kidneys develop on the side of the aorta, so the renal arteries are lateral branches, and gonadal arteries are anterolateral branches. Direction of the arteries is important because there's a rule says lymphatic follow vein follow artery. That also means lymphatic follow arteries. So if you know the direction of the arteries, you know the direction of the lymphatics as well. For example, the gut lymphatics will be coming in front of the aorta, pre-aortic lymph node, whereas the gonadal lymphatics will be coming anterolateral to the aorta, that is pre-aortic and para-aortic lymph nodes. Now, as we said, arteries will be followed by the veins. Let us have a look over the veins as well. Veins usually have the same name as the arteries. You can see femoral artery and femoral vein, external iliac artery, external iliac vein, internal iliac artery, internal iliac vein, common iliac artery, common iliac vein. But here, the two common iliac vein will be joining to form inferior vena cava, which is then receiving the gonadal veins and the adrenal veins. Remember, right gonadal vein and the right adrenal vein drain directly into the IVC, whereas on the left side, the left gonadal vein and the left adrenal vein first drain into the left renal vein, and then the left renal vein drain into inferior vena cava. The lever, which is under the diaphragm, should drain into inferior vena cava. That is the rule. So the lever will be sending the metabolites via the three major hepatic veins into the inferior vena cava, and then the inferior vena cava will be puncturing the central tendon of diaphragm at the T8 vertebra to enter the right atrium. Now, as we said, the lymphatic follow vein follow artery, or you can say lymphatic follow artery, the testis or the ovaries, where are the lymphatics going? They will be going towards the pre and para-aortic lymph node. But remember, the first answer should be para-aortic lymph node on the side of the aorta. And some books mention it as pre-aortic lymph node also, anterolateral to the abdominal aorta, as are the gonadal vessels, anterolateral branches of abdominal aorta. So lymphatic is also anterolateral to aorta. Now here we are going to revise the neurovascular bundle for the abdomen region. As we said, foregut is still the proximal half of duodenum, whereas the distal half of duodenum belong to midgut till the right 2/3 of transverse colon, whereas the left 1/3 of transverse colon and the rectum anal canal belong to hindgut. If you're talking about the foregut, celiac artery branches will be supplying the foregut till the proximal half of duodenum, whereas the superior mesenteric artery branches will be supplying till the right 2/3 of transverse colon, along with the distal half of the duodenum, whereas the inferior mesenteric artery branches will be supplying the left 1/3 of transverse colon and the rectum upper anal canal as well. When it comes to the vein, there's a portal venous circulation, which is carrying the nutrients absorbed from the intestine and the gut tube towards the liver for metabolism. And then we have the lymphatics. Lymphatics follow vein, follow arteries. So lymphatic follow arteries is evident here. Celiac lymphatics follow the branches of celiac artery. Superior mesenteric lymphatics follow the branches of superior mesenteric artery. Inferior mesenteric lymphatics follow the branches of inferior mesenteric artery. As it comes to parasympathetic system, vagus nerve supply the foregut and the midgut till the right 2/3 of transverse colon. But the left 1/3 of transverse colon, the hindgut, is under the nervi irrigantes, also called pelvic splanchnic nerve, nerve as they supply the pelvic viscera as well, bearing root value as 2, 3, 4. What will happen if we activate the pelvic splanchnic nerve or nervi irrigantes? They are parasympathetic evacuatory nerve, increasing peristalsis and relaxing the sphincter. So there will be urination and defecation, bladder bubble evacuation. Then how do we call the storage? Bladder bubble storage. For that purpose, you need the sympathetic storage. And sympathetic system will cause storage by reducing the peristalsis. For example, the greater splanchnic nerve, having 5 root values starting with number 5, that is thoracic 5 to 9, is going to reduce the peristalsis of the foregut derivative, for example, stomach. Now, when you reduce the peristalsis of the stomach, there will be storage of the stomach and distension of the stomach. The pain of the stomach is carried by the same nerve itself, the greater splanchnic nerve. So it is a mixed nerve, sensory motor nerve. First, it is reducing the peristalsis for storage of stomach. And when the stomach has storage distension pain, it is carrying the pain also. Refer to this root value, which is T5 to T9, especially the T7 epigastrium. So foregut pain will be felt in the epigastrium, whereas the midgut pain is felt periumbilical region, the T10 dermatome. The nerve of midgut is lesser splanchnic nerve, carrying the pain of Meckel's diverticulum or the acute appendicitis, periumbilical pain. T1011 is the root value. The lesser splanchnic nerve of the midgut. When it comes to hindgut, the nerve of the hindgut is the lumbar splanchnic nerve, bearing the root value L1L2, though it also carries T12. And if there is a pain of the hindgut, for example rectum, that will be felt in the suprapubic region, which is L1 dermatome. Understand that the gut pain is always felt in the midline until there is a local area involvement. It is the epigastrium, periumbilical or suprapubic region. But if there is a local area involvement, for example acute appendicitis leading to local peritonitis, then the pain may be referring to right iliac fossa, begins in the periumbilical region and refers to the right iliac fossa later, due to local area involvement. Otherwise, gut pain is always felt in the midline, since the gut tube develop in the midline, in front of the aorta. The pain also stays in the midline, embryologically. Now, the sympathetic parasympathetic nerve are going to make some plexuses in front of the aorta. Like in front of the celiac artery, you have the celiac plexus controlling the viscera of the foregut derivative. Here, the vagus nerve is contributing, and also contributing are the sympathetic nerve like greater spinal nerve, lesser spinal nerve. The arterial branches of celiac trunk will be carrying the fibers towards the foregut derivative. Similarly, you have superior mesenteric artery surrounded by superior mesenteric plexus supplying the midgut derivative. Then you have the renal plexus to supply kidney, renal plexus to supply the gonads. You'll also see there is a superior hypogastric plexus at the bifurcation of the abdominal aorta into common iliac artery. It is chiefly sympathetic in nature, but partly parasympathetic, as some of the nervi irrigantes fibers are ascending here. When it comes to inferior hypogastric plexus, which is on the side of the pelvic viscera, it is chiefly parasympathetic, contributed by nervi irrigantes in the pelvis, though it receives of some sympathetic fibers also via the superior hypogastric nerves, coming from the superior hypogastric plexus at the sacral promontory there. And remember that sympathetic system is for storage by reducing peristalsis, and parasympathetic is for evacuation by increasing peristalsis and relaxing the sphincter. It can cause urination and defecation, bladder bubble evacuation by nervi irrigantes, pelvic splanchnic nerves. Now, when it comes to thoracolumbar flow, the sympathetic flow, we have lateral horn cells having the sympathetic neuron, starting at thoracic 1, reaching the lumbar 2 root value, and the 5 root values starting with number 5, that is T5 to T9, is greater splanchnic nerve supplying the foregut derivative. T1011 is lesser splanchnic nerve supplying the midgut derivative. And T12 is the least splanchnic nerve supplying the kidney. The T12 will reach the hindgut and pelvic viscera as well, along with L12, that is lumbar splanchnic nerve. Lumbar splanchnic nerve with the root value T12 L12 will be supplying the hindgut and the pelvic viscera. Included are the uterus, the rectum and urinary bladder as well. The referred pain of the foregut will be felt in T5 to T9 dermatome, especially T7 epigastrium. Midgut pain will be periumbilical T10, and kidney pain is T12, that is renal angle, below the 12th rib, and the hindgut pain is in the suprapubic region, anteromedial thigh L12. That is why it is important to know the dermatome as well. We'll find that shoulder tip is C4C4, which is the root value of the phrenic nerve also. If there's a phrenic nerve irritation in the abdomen, like acute cholecystitis, then the referred pain will be felt at the right shoulder tip. If there's a spleen rupture irritating the phrenic nerve, then the referred pain will be felt at the left shoulder tip, for which we'll see a diagram as well. T4 is the nipple level, T7 is the epigastrium, foregut pain, and T10 is the periumbilical region, the midgut pain, and L1 is the suprapubic region, the hindgut pain. L1 is the inguinal region where the lower limb begins. Let us take a case of acute appendicitis, which is midgut pain carried by the lesser splenic nerve of the midgut and reaching the sympathetic chain and reaching the spinal nerve, passing through the dorsal root, entering the spinal cord there. Then start the second order neuron, which is lateral spinothalamic tract, running contralaterally to carry the pain to the brain. And brain will project this pain on the skin with the same root value as the viscera. Like the vermiform appendix has T10 root value and will be felt at T10 dermatome, periumbilical skin. Since the visceral pain is dull pain, brain has the capacity to project the pain on skin, which is somatic pain, sharp pain, so that you can notice it immediately. So as I suggested, if there is irritation on the phrenic nerve due to acute cholecystitis, pain can be felt in the right shoulder tip. If there is a spleen rupture irritating the phrenic nerve, then there will be shoulder pain felt on the left tip of shoulder. And gut pain is in the midline. As you say, if it is the stomach or the pancreas for gut pain, perium epigastric region. And if it is the Meckel's diverticulum or acute appendicitis, it is periumbilical region, T10 dermatome. And if it is rectum pain, suprapubic, L1 dermatome. So gut pain is in the midline until there is a local area involvement, like the appendix pain can fell at the right iliac fossa if there is a local peritonitis in the region. As it comes to the kidney pain, it is a radiating pain from loin to the groin. In fact, it is along the T12 dermatome, but kidney is a large organ having 5 root values, which is T12 plus minus 2. When you say so, it means T10, 11, 12 and L1, 2. T10, 11, 12 is the loin area and L1, 2 anteromedial thigh is the groin area. So radiating pain from loin to groin is the kidney pain, renal colic. When we talk about the development of the testis, it begins in the abdomen, and that is the 7th week of the development, 2nd month of intrauterine life. But then in the 3rd month, it will be reaching the pelvis region and being pulled at the caudal pole by a fibrous structure called gubernaculum towards the base of the scrotum. As it is passing through the abdomen into the pelvis, it will be staying near the deep inguinal ring, and then passing inguinal canal, it has to enter the scrotum. It is being followed by a double fold of peritoneum, which is called as the process vaginalis, and it will be reaching the scrotum along with the testis. Let us look at the next stage now. As you understand that this double fold of peritoneum is following the testis into the scrotum, the testis has to reach the scrotum before the baby is born. In some babies, it may be reaching after birth, but mostly at the 9th month of intrauterine life, it should reach the base of the scrotum. Following is the testicular vessels from the abdomen region, inside a cord which is called a spermatic cord, which also carries the ductus deferens, which is having the sperms of the testis being sent towards the prostatic urethra in the pelvis. As the testis is being pulled into the pelvis and the scrotum, it will bring some of the abdominal wall muscles along with that, which we have to discuss, will be giving us covering of the scrotum as well as the spermatic cord there. So finally, when the testis has reached the scrotum, it will be covered by a double fold of peritoneum, which is called as tunica vaginalis, which is a remnant of the process vaginalis. Actually, the process vaginalis is obliterated. What will happen if there is a persisting process vaginalis? Then there will be a problem, and it might happen that intestine from the abdomen or omentum from the abdomen might enter the inguinal canal and the scrotum and causing indirect inguinal hernia, which can happen in a male as well as female, usually in the young age. Now here is the spermatic cord, which is following the testis toward the scrotum, will be containing the ductus deferens, which is itself continuation of epididymis, taking the sperms towards the prostatic urethra in the pelvis. It is also followed by testicular vessels towards the scrotum and the testis, all content of the spermatic cord. Remember, testis is passing the inguinal canal in the 7th month of intrauterine life, which is 25 to 28th week of intrauterine life, and reaches the social inguinal ring. From social inguinal ring to reach the scrotum, it takes around 1.5 months, but is at the base of scrotum before birth of the babies, most of the babies. Now, as we look at the anterior abdominal wall, this is the umbilicus there. This is the anterior superior spine on the hip bone. Attaching to that is the inguinal ligament, which also attaches to pubic tubercle at the hip bone. If you want to take a femoral artery pulse there, then you can be taking that at mid-inguinal point, which is you have to take a point at the anterior superior spine and the pubis symphysis, midline of the body, and between the 2 points you take the mid-inguinal point. There you can take the femoral artery pulse. Just above that is the deep inguinal ring, where the testis fetus was resting from 3rd month to 7th month of intrauterine life. At the 7th month, it will be passing through the inguinal canal and takes only 2 to 3 days to reach the superficial inguinal ring. But from the superficial inguinal ring to reach the base of scrotum, it will take 1.5 months, reaching there just before birth. Following it is the spermatic cord containing the ductus deferens and the testicular vessels. In this process, there are some muscles which are giving some contribution towards the covering of the spermatic cord and scrotum, and we want to talk about those muscles. They are anterior abdominal wall muscles like external oblique, deep to that internal oblique, and still deeper is the transverse abdominis, and still deeper will be transverse salis fascia. As you see, the most anterior muscle is the external oblique muscle, and it is running antero-inferiorly, and if you remove that, deep to that will be the internal oblique, which is running exactly opposite superior-medially. If you remove that also, then there's a transverse abdominis running transversely, and if you remove that also, then deep to that will be transverse salis fascia, the deepermost. Now these muscles are inserted into rectus sheath, which is covering the rectus abdominis muscle here, one on each side, and these muscle aponeurosis is merging at the linea alba, which is in the midline, and there will be one linea semilunaris also, which is the lateral border of the rectus abdominis muscle, where you'll find that the various muscles are contributing to the rectus sheath. It is also understood that external oblique muscle aponeurosis is having an opening called superficial inguinal ring for the passage of the testis and spermatic cord, and it is forming the anterior wall of the inguinal canal. Not only anterior wall, but also the floor, as it is forming the inguinal ligament. So external oblique muscle remains antero-inferior to the inguinal canal. Now we are taking a transverse section of the abdomen region to discuss the various muscles aponeurosis contributing to the rectus sheath containing the rectus abdominis muscle. Let us magnify the picture. Understand the most anterior thing will be the skin, deep to that will be the fascia, and deep to that will be the muscles. External oblique, internal oblique, and transverse abdominis muscle, and deepermost will be the transverse salis fascia, and deep to that will be the peritoneum, lining the peritoneal cavity containing the peritoneal viscera. Now this is the rectus abdominis muscle, which is the midline muscle, and this is the midline, that is linea alba, and here you have linea semilunaris. Now rectus abdominis is covered by anterior layer of rectus sheath and posterior layer of rectus sheath. Anteriorly, it is contributed by two muscles, that is external oblique muscle aponeurosis and also the internal oblique anterior layer. Whereas internal oblique, the posterior layer of the fascia, is contributing to posterior part of the rectus sheath, which is additionally contributed by transverse abdominis fascia. That means rectus sheath has anterior layer which is contributed by the external oblique aponeurosis and partly internal oblique aponeurosis, whereas internal oblique aponeurosis is splitting to give posterior contribution as well, while the additional muscle will be the transverse abdominis muscle there. Now if you look at the rectus sheath, at a higher level, you will find that there the rectus abdominis muscle is directly lying on the costal cartilage, and the rectus sheath is present only the anterior aspect. And similarly, if you come to the lower part, lower abdomen, especially below the arcuate line, you'll find that again the rectus abdominis muscle is directly sitting on the deeper fascia, that is transverse salis fascia, and all the muscles are contributing only to the anterior layers of the rectus sheath. In fact, rectus sheath is missing posteriorly behind the rectus abdominis muscle in the lower region of the abdomen wall. So as you can see in the upper part, the rectus muscle is directly lying over the costal cartilages and deferred process there, and it has no posterior layer of the rectus sheath. There's only anterior layer of rectus sheath, which is itself contributed by only one muscle, which is the external oblique muscle. Normally, the rectus sheath, which covered the rectus abdominis muscle, should be contributed by three muscles, like you see. The external oblique is contributing anterior layer. The internal oblique is splitting into two, so that it contributes to the anterior lamina as well as posterior lamina of the rectus sheath, and the internal muscle is transverse abdominis muscle, which contribute only to the posterior layer of rectus sheath. Now in the lower part of the abdomen, below the arcuate line, you'll find the rectus abdominis muscle is lying directly on the deeper fascia, which is fascia transverse salis. As all the muscles may be external, internal, or transverse abdominis, contributions go anterior to the rectus abdominis muscle. So rectus sheath is present only anteriorly, and missing is the posterior layer of rectus sheath then in the lower part of the abdominal wall, below the arcuate line. Now we want to talk more about the boundaries of the inguinal canal. As we suggested, external oblique muscle is anterior and also inferior as the floor, forming inguinal ligament. It has an opening called as external oblique aponeurotic opening, which is called superficial inguinal ring for the passage of testis and the spermatic cord. Then where is this deep inguinal ring present? It is an opening in the fascia transverse salis, deeply. Let us look at the details of the muscles here now and their contribution to spermatic cord and the scrotum layers as well. We are looking at the anterior abdominal wall, the right-sided inguinal canal here, and as you can see, the most anterior muscle is external oblique aponeurosis. It remains anterior wall of the inguinal canal through which is passing the spermatic cord. Spermatic cord is coming from the pelvis region and entering the inguinal canal and then the scrotum to reach the testis. It will be carrying the testicular vessels towards the testis and carrying ductus deferens from the testis towards the pelvis region. In that process of passing through the inguinal canal, it will receive some of the contribution by various muscles, like the external oblique muscle is giving the external spermatic fascia, and the deeper muscle, which is internal oblique muscle, is giving the cremasteric fascia and cremaster muscle as well. Whereas the transverse abdominis muscle, which is deeper, do not contribute anything to the spermatic cord. It is the transversalis fascia which will be contributing to the internal spermatic fascia. So there is internal spermatic fascia which is coming from transversalis fascia. Then there is cremaster muscle, cremaster fascia which came from internal oblique muscle. And then there is external spermatic fascia which came from external oblique aponeurosis. Understand here that the external oblique muscle remains anterior to the inguinal canal and is also inferior, forming the floor of the inguinal canal. Whereas the internal oblique muscle is arching fibers lying anterior, superior, and posterior to the spermatic cord. That means anterior wall, roof, and posterior wall of the inguinal canal. Deeper to that is the transverse abdominal muscle, which is much more lateral. So it will be contributing only to the roof and the posterior wall of inguinal canal. Posteriorly, it will be merging with the tendon of the previous muscle, which is the internal oblique, to form a conjoint tendon at the posterior wall of the inguinal canal, lying behind the spermatic cord, passing the inguinal canal. And still deeper is the transversalis fascia, which is having an opening called as a deep inguinal ring for the passage of the spermatic cord. Now understand that these muscles of the anterior abdominal wall, as they form the layers of the spermatic cord, will also form the layers of the scrotum following the testis. And it is the external oblique aponeurosis which will form external spermatic fascia over the scrotum, as it was doing for the spermatic cord as well. Deeper to that is internal oblique muscle, forming the cremasteric fascia cremaster muscle in the scrotum region also, as it was doing for spermatic cord. So internal oblique muscle form the cremaster muscle and cremasteric fascia. Whereas the deeper muscle, transverse abdominis muscle, stops there, do not form any covering for spermatic cord or the scrotum. It is a still deeper layer which is the transversalis fascia, which will come as the internal spermatic fascia for the scrotum as well as the spermatic cord. It is the transversalis fascia forming internal spermatic fascia. So there is internal and external spermatic fascia. In between is the cremaster fascia. External spermatic fascia coming from external oblique muscle, internal spermatic fascia coming from the transversalis fascia, whereas the internal oblique forming the intermediate cremasteric fascia. You already know about the peritoneum. It would have formed the process vaginalis, which is normally obliterated. If it is persistent, there will be a chance of indirect inguinal hernia. So as you can see, there is the obliterated process vaginalis. If it remains open, then it might pull the omentum or intestine into the scrotum, causing indirect inguinal hernia. And a double fold of peritoneum, which is covering the testis in the scrotum, is called tunica vaginalis. Testis form the sperm collected by the epididymis, which is for storage and maturity, motility of the sperm, and pushing it into the ductus deferens, which passes through the spermatic cord inside the inguinal canal, the deep inguinal ring, and reach the pelvis region to put the sperm into the prostatic urethra. Now, this cremaster muscle, if contracts, will elevate the testicles, especially in cold environment. The testes must stay close to the body wall. Or if you are touching the inner thigh of a male, it will be undergoing contraction called as the cremaster reflex. As you touch the upper medial thigh of a male, you will be activating a nerve, which is femoral branch of genitofemoral nerve. It's a sensory afferent nerve carrying the information of the touch to the spinal cord number L1, and from there a motor nerve is activated, which is genital branch of genitofemoral nerve, and will be contracting the cremaster muscle, elevating the testicle along with the scrotum on the same side, ipsilateral elevation. The nerve is same nerve, may be sensory or motor. Though it is understood, the sensory component can also be carried by additionally ilioinguinal nerve, supplying the upper medial thigh hair. Now we want to talk about the boundaries of the femoral ring, through which pass some of the lymphatics of the thigh into the pelvis, but it can be followed backward by the intestine into the femoral ring and into the thigh, causing femoral hernia. Now we are looking at the right-sided femoral ring and want to know about the boundaries. Let us magnify the area. As you can understand, this is the anterocephalic spine on the hip bone, giving the inguinal ligament attaching to pubic tubercle on the hip bone, sending a posterior extension called as the pectineal ligament of the Cooper. And running anterior posterior between the two is the lacunar ligament, forming medial boundary of the femoral ring. Femoral ring has the anterior boundary by the inguinal ligament and posterior boundary by the pectineal ligament of Cooper, attaching to pectineal line on the hip bone, and medially is the lacunar ligament. Laterally is the vein of the femur, which is the femoral vein there. Now, as the intestine might follow lymphatics into thigh, usually in a female, leading to femoral hernia, it is difficult to reduce the intestine back into pelvis because the ring is narrow. You have to enlarge the ring by cutting lacunar ligament here and then reduce the femoral hernia. After reduction, put a mesh here to prevent the recurrence. Let us look at some more details now. As we are talking about the right femoral ring here, let us look at the boundaries of femoral triangle as well. Femoral triangle has a base of inguinal ligament. Laterally is a muscle sartorius. Medially is the adductor longus. Understand MM, the medial margin of the rectal longus, MM, the medial margin of sartorius, and then inguinal ligament is the boundaries. You have to understand that adductor longus is at the floor of the femoral triangle, whereas sartorius muscle is outside the femoral triangle. The most medial content is the inguinal lymphatics, and there's a rule which we follow: lymphatic follow vein, follow artery. So the lymphatics, which are deep inguinal lymphatics running towards the pelvis, are following the vein and the artery, namely femoral vein and femoral artery. They're all covered by a femoral sheath, whereas the femoral nerve is outside the femoral sheath, but inside the femoral triangle. The most lateral content is femoral nerve, lying outside the femoral sheath, and most medial content is the lymphatics, sometime followed by the intestine, leading to femoral hernia. The intestine from the pelvis will move into the femoral ring and into femoral canal, inside the femoral sheath, leading to femoral hernia. Let us look at some more details. Then, here we find it is the right-sided femoral hernia, and the intestine has come from the pelvis, passing through the femoral ring, and is present in the thigh region. Now, it is difficult to reduce this femoral hernia because the femoral ring is narrow, bounded by the anterior inguinal ligament, medial lacunar ligament, and posterior Cooper ligament. Laterally is a septum which separates the femoral ring from the femoral vein. Now, to reduce this hernia, I have to enlarge the femoral ring, and I will be cutting the lacunar ligament. But while you cut the lacunar ligament, be careful, one artery can be running here, which is called accessory obturator artery, branch of inferior epigastric artery, which itself is a branch of which passes deep to inguinal ligament to enter the femoral triangle and become the femoral artery. So femoral artery is a content of femoral triangle, continuation of the external iliac artery in the pelvis region. External iliac artery was giving inferior epigastric artery, which enters the rectus sheath here and is giving sometime the accessory obturator artery, aberrant obturator artery, which will be running on the lacunar ligaments, and you should be careful while cutting the lacunar ligaments, don't damage this artery. Understand, femoral hernia is lying inferior lateral to pubic tubercle. The neck of the femoral hernia lies inferior lateral to pubic tubercle, and this time the intestine is following the lymphatics and is enclosed in the femoral sheath in the femoral canal. You can notice the femoral nerve is outside the femoral sheath, whereas the femoral sheath encloses the lymphatics along with intestine, following the vein, following the artery, all inside the femoral sheath. And remember that iliopsoas muscle is at the floor of the femoral triangle. Along with that is a pectineus muscle and also the adductor longus muscle, whereas the sartorius muscle is outside the floor of the femoral triangle. It just forms the boundary of the femoral triangle. Now, here is a case of persisting process vaginalis leading to indirect inguinal hernia. In that case, the intestine in the pelvis will enter deep inguinal ring, inguinal canal, superficial inguinal ring, and then the scrotum or the labia majora if it is a female. And these hernias are lying superior-medial to the pubic tubercle, as compared with the femoral hernia, which is lying inferior lateral to pubic tubercle. Let us compare the two now. At the right-sided inguinal region and the femoral region, and as we can see, these are the external iliac vessels passing under inguinal ligament to become femoral artery vessels. The external iliac vessels are giving inferior epigastric vessels which will enter the rectus sheath, covering the rectus abdominis muscle in the midline. And these vessels become the boundary line to differentiate between the direct inguinal hernia and indirect inguinal hernia. The direct inguinal hernia, which is passing through Hasselbeck's triangle, is more commonly seen in the elderly individuals, whereas the indirect inguinal hernia, which lie lateral to the inferior epigastric vessels, will be seen mostly in the young people. Here the hernia will be passing deep inguinal ring, inguinal canal, and come off the superficial inguinal ring to enter scrotum or labia majora. As is understood, femoral hernia are inferolateral to the pubic tubercle, whereas inguinal hernia are superior-medial to pubic tubercle. This is the Hasselbeck triangle, the site of the direct inguinal hernia, bounded by the inferior epigastric vessel laterally, base is the inguinal ligament, and medially is the rectus abdominis muscle. Let us look at a similar diagram for identifying the inguinal hernia from the femoral hernia. So here you can see inferior epigastric vessels. Lateral to that is the deep inguinal ring, opening in the fascia transversalis, through which the testis was passing, and then the spermatic cord, and then came the intestine. Indirect inguinal hernia due to persistent process vaginalis, commonly seen in the young male, can be also a female. Passing the inguinal canal, the intestine is superior-medial to pubic tubercle and entering the scrotum or labia majora. This is indirect inguinal hernia. Whereas if you're talking about the direct inguinal hernia, which is lying posterior to that, came from the Hasselbeck's triangle, lying medial to the inferior epigastric vessels. Now maybe it is direct inguinal hernia or indirect inguinal hernia. Both of them, the neck is superior-medial to pubic tubercle. If the neck is inferior lateral to pubic tubercle, then it will be femoral hernia, intestine in the thigh, lying medial to the femoral vessels. There. Now let us talk about the Doom's triangle in this region. As is understood, the abdominal aorta is giving testicular artery, anterolateral branch, which is going to supply the testis. And as it comes to the pelvis region, it will be entering the deep inguinal ring. Let us magnify this area now. So here are the testicular vessels supplying the testis. They have to pass the deep inguinal ring, spermatic cord, passing in the inguinal canal. Spermatic cord will be reaching the testis, supplying the testis. So the testis will be giving the sperm, which will be entering the ductus deferens, which itself is the content of spermatic cord. Running inside spermatic cord, the ductus deferens is in the inguinal canal and passing the deep inguinal ring. It leaves the testicular vessels and be a content of spermatic cord. Hooking medial, D is the inferior epigastric vessels. The spermatic cord or the deep inguinal ring lies lateral to the inferior epigastric vessels. Now, the ductus deferens is coming towards the pelvis and become the common ejaculatory duct. Open into the prostatic urethra, ejaculate the semen into prostatic urethra, which will come out of the penile urethra then. Now, here you will see we have the triangle of the Doom. It is called so because if you operate in this area, putting some staples, while doing laparoscopic hernia repair, you might be bleeding these vessels, external iliac vessels. So it's a triangle. What is the base and the apex? It's a triangle, so the base is some peritoneal fold covering the external iliac artery and vein, and the apex is the deep inguinal ring here. The lateral boundary is testicular vessels, and medial boundary is the ductus deferens, and the contents of the triangle are the external iliac vessels. There is a triangle of Payne also, which is lateral to this triangle of Doom here. The Payne of triangle, as you see, is also having the boundary of testicular vessels. On one side, at the base you have some peritoneal fold, and on the other side you will have a iliopubic tract coming from ilium bone towards the pubis bone. This iliopubic tract is running deep and parallel to inguinal ligament. So iliopubic tract and testicular vessels, the apex is the deep inguinal ring again, and the base is some peritoneal fold again, but more laterally. The content are two nerves. One is the lateral cutaneous nerve of thigh, supplying the lateral thigh, and the other is femoral branch of genitofemoral nerve, which carry the cremaster reflex. If you are operating laparoscopically for hernia repair, you're not supposed to put staples in this area or any tack here, because you might involve the femoral branch of genitofemoral nerve, leading to post-op pain in the upper middle thigh, or you may damage the lateral cutaneous nerve of thigh, leading to features of myalgia paresthetica, pain in the upper lateral thigh. So there are two nerves content of the triangle of Payne which needs to be avoided while putting a mesh here for hernia repair. Here we discuss some details of the liver. If you're doing a liver transplantation, you have to cut the liver into two surgical halves. There is a right surgical liver and left surgical liver. The right surgical liver is given to the recipient and left is left with the donor, which will be 30 to 40% of liver, whereas 60 to 70% of liver is given to the recipient. To divide into right and left lobe, you have to follow middle hepatic vein, which cannot be seen, so you need a surface marking called Cantley's line, which can be put at the midpoint of gallbladder, joining the midpoint of inferior vena cava, and cutting the liver on that Cantley's line, you will reach the middle hepatic vein and divide the liver into right surgical liver and left surgical liver. Anatomically, if you follow falciform ligament of liver, the liver to the left side of that is called left anatomical lobe of liver. But surgically, this is the left surgical lobe of liver, decided by a Cantley's line or middle hepatic vein. Liver can be divided into 4 sectors and 8 segments. following the portal vein. Plus, you can also follow hepatic vein. But if to choose between two, portal vein is the first answer. Now let us magnify this area to see the details of the hepatic vein. As is understood, hepatic veins are 3 in number. We have just followed the middle hepatic vein, the Cantley's line. Otherwise, there is a right hepatic vein and left hepatic vein also. As a surgeon, you are supposed to follow them because they are intersectoral in nature and create 4 sectors of the liver. If you want to do sectorectomy, removing one sector from the other sector, follow these veins to minimize bleeding and tissue damage. They drain the liver circulation into the inferior vena cava. But if you want to have the 8 segments of liver, then you have to follow the other vein, which is portal vein as well. So let us do that now. It is understood that portal vein brings the nutrients absorbed from the gut tube into the liver for metabolism. And if you follow its branches, then you can divide the liver into 8 segments according to Quinault classification. The segment 1 is the smallest of all, caudate lobe of liver, and is hidden behind segment number 4, which is quite large. It is 4A, 4B, and 4A superior, 4B inferior. To have more details of that, let us look at another diagram. But understand that the liver metabolism, the metabolites will be carried by the 3 hepatic veins, which are intersectoral in nature and carry the metabolites towards the inferior vena cava, which will carry it towards the heart and distributed throughout the body after that. Now here we said that 4 segment is large, 4A is superior, 4B inferior, and caudate lobe segment 1 is small, hidden behind 4A. Caudate lobe you cannot see from the front view, you have to look at the posterior view of the liver to visualize it. And similar is 4B posterior, which is called quadrate lobe of the liver. So caudate and quadrate can be seen only from posterior view of the liver. As you can see, there are 4 sectors in the liver: sector 1, sector 2, sector 3, and sector 4, decided by these intersectoral veins, which are named as middle hepatic vein, right hepatic vein, left hepatic vein, draining the metabolites into the inferior vena cava. Now note one peculiar thing here. The caudate lobe drains directly into inferior vena cava and not into any of the major hepatic veins. If there is hepatic vein thrombosis, as might happen in Budd-Chiari syndrome, which will lead to portal hypertension and cirrhosis, one part of liver will survive. That is the caudate lobe of liver, because it has nothing to do with the hepatic vein thrombosis, as it is directly draining into inferior vena cava. So it will escape the injury of the Budd-Chiari syndrome and in fact undergo compensatory hypertrophy because the rest of the liver was dying. It has to take over the function of the entire liver, which is anyway not possible, but it will try. Now, when it comes to the counting of the segments, according to Quinault classification, you are following the portal vein and you have to search for the segment 1, which is caudate lobe present on the posterior aspect of the liver. Once you found it, then you have to count clockwise. It will be 2, 3, 4, which is the left surgical lever, and it is the 5, 6, 7, 8, which is the right surgical lever. 8 will come close to 1 in a clockwise fashion. To see the caudate lobe, you have to look from the posterior view of the liver. Let's do that now. This is the caudate lobe of liver, segment 1, posterior view of the liver, and it is sandwiched between inferior vena cava to the right side and fissure for ligamentum venosum to the left side. This fissure for ligamentum venosum, seen posterior view of liver, is separating segment 1 from segment 2. And then there is a fissure for ligamentum teres, separating segment 3 and segment 4. Segment 4B, which is caudate lobe, is sandwiched between the fissure for ligamentum teres left side and gallbladder on the right side. And this is the porta hepatis region, where the DAV structure will be entering. Duct is bile duct, A is artery, hepatic artery, and V is vein, portal vein. Now we got a case of hemangioma to the left of the falciform ligament, and we want to sacrifice segment number 2 and 3. We have to put our scalpel into fissure for ligamentum venosum and fissure for ligamentum teres because it is avascular plane and you can remove this part of the liver. You will preserve 1 and 4 in that process, sacrificing 2 and 3 along with hemangioma. Let us look at this hemangioma from the front view as well. That hemangioma was to the left side of the falciform ligament, and in the front view you can see the hemangioma. You have removed the segment 2 and 3 and preserving 1 and 4 on the left side of the falciform ligament. Your operative procedure was to put a scalpel behind in the fissure for ligamentum teres posteriorly and fissure for ligamentum venosum posteriorly, and remove the segment 2 and 3 to remove the hemangioma. Let us look at the post-op diagram as well. Here is the post-op diagram. You have sacrificed 2 and 3 along with hemangioma, but you have preserved 1 and 4. But you can see only 4. 1 cannot be seen as it lies behind segment number 4. The caudate lobe is present posterior to the 4A, the superior part of segment 4, which is quite large. Previously, it was understood that segment 1, 2, 3, 4, the left surgical lever will drain into the left hepatic duct, the bile, whereas segment number 5, 6, 7, 8 will drain the bile into the right hepatic duct. But later it was realized that segment 1 is a boundary line structure, partly drained into right hepatic duct as well. So it has double duct drainage. It drains into left hepatic duct as well as right hepatic duct. So it was called as a separate surgical unit, the third surgical lever. The left surgical lever is 2, 3, 4 and right surgical lever is 5, 6, 7, 8. Segment 1 or caudate lobe belongs to both the levers, so we call it as third surgical lever. It has double artery, double vein and double duct supply. It is supplied by right and left hepatic artery. It is supplied by right and left branch of portal vein, and it is draining the bile into right and left hepatic duct both. It has everything double, 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 and it is peculiar in the view that it drains directly into the inferior vena cava as well, hence escaping the injury of Budd-Chiari syndrome we witnessed earlier. Now, as we can see, this is right hepatic duct, which will be receiving the bile from the right surgical lever, which is segment number 5, 6, 7, 8. Whereas this is the left hepatic duct receiving the bile from the segment number 2, 3, 4 left surgical lever. Whereas the caudate lobe will drain into both the hepatic ducts. Now, hepatic ducts are joining to form common hepatic duct, which will be joined by the cystic duct, and then they form common bile duct here. This bile duct will be passing behind the first part of the duodenum to open to second part of the duodenum and receiving some pancreatic secretion also. There's a hepatopancreatic duct which will be opening the second part of the duodenum on the medial wall. It will have a sphincter of Oddi having 3 mini sphincter. There's a biliary sphincter for controlling bile, pancreatic sphincter to control the pancreatic flow, and a common ampullary sphincter to control both the flow into second part of the duodenum. That sphincter of Oddi has 3 mini sphincters. As we talk about the gallbladder, it will store the bile before it is being poured into the second part of the duodenum via the bile duct. It will have a heartburn pouch, which is in the neck region, and maybe sometime having inflammatory adhesions with the duodenum, which can be troublesome. This is the cystic duct, which will have a spiral valve of Heaster, which is a permanent valve, though it is called as a sphincter to regulate the bile flow into the bile duct. But it is doubtful because it is a permanent mucosal fold, so cannot work like a true valve as such. Here you will find the Callet's triangle as well. Let us magnify this area to discuss the boundaries of Callet's triangle then. Callet's triangle is bounded by cystic duct on right side, common hepatic duct on the left side, and cystic artery on the base. Some people mistake Callet's triangle with the cystohepatic triangle there, which is a different triangle. There you have the triangle of cholecystectomy. The base is the inferior border of liver. Otherwise, you have cystic duct and common hepatic duct as well. But that is different from Callet's triangle. In the Callet's triangle, you must take cystic artery as the base, as given in the latest edition of Gray's Anatomy, 41st edition. It will contain a lymph node of LUND and comes as a question. Cystohepatic lymph node of LUND. This diagram is going to tell us about the formation of the lesser sac, which is a small space behind the stomach. Otherwise, most of the peritoneal cavity is greater sac. If you remember, we have mentioned that the stomach, lesser curvature is anterior in the beginning and the greater curvature is posterior in the beginning. Anteriorly, you have the ventral mesentery where the liver was developing, and posteriorly you have the dorsal mesentery where the spleen was developing. Then we saw that the liver, which is developing anteriorly in the ventral mesentery, was having a ligament here called as the lesser omentum attaching to lesser curvature of the stomach, and also porta hepatis of liver. Whereas posteriorly you have the splenogastric ligament attaching to the greater curvature of the stomach. Now, the stomach rotates to right side by 90 degree. The lesser curvature goes to the right side and greater curvature comes to the left side. As the stomach is rotating to right side by 90 degree, it will pull the lever to the right side, and the greater curvature along with the spleen and the sphenogastric ligament will be pulled to the left side. In normal adult, the lever is to the right side and spleen is to the left side. So as the lesser curvature is going to right side along with the lever, you'll find the space which is on the right side of the stomach is going behind the stomach and is called as lesser sac. Other name is omental bursa, and it is important in the view that if there is a posterior perforation of the gastric ulcer, the content will be found behind the stomach in lesser sac. And if you want to remove those contents, your suction tube will go into greater sac in front of the stomach. Then you have to pass the epiploic foramen of Winslow to enter the lesser sac and drain the gastric content from there. We want to know what are the boundaries of the epiploic foramen of Winslow in that context. Here is one more diagram which will tell us about the stomach rotating to right side by 90 degree. In the beginning, the lesser curvature of stomach is anterior, greater curvature is posterior. But gradually, you'll find that lesser curvature comes to right side and the greater curvature is going to the left side. In that process, when stomach rotates to right side by 90 degree, there is a peritoneal pouch, peritoneal space formed behind the stomach and is called as lesser sac or the omental bursa. Importance is when there is a posterior perforation of gastric ulcer, which is rare to see, but if happens that the content of the stomach will be found in the lesser sac, posterior to stomach. If you want to remove those gastric content from there, you'll have to follow epiploic foramen of Winslow and reach behind the stomach and aspirate those content from there using the suction tube. You can also notice that the right vagus is going to become the posterior vagal trunk and the left vagus is going to become anterior vagal trunk. As the stomach rotates to right side by 90 degree, the nerves which are on the left, they will come anterior and the nerve which is on the right will come posterior. So left vagus become anterior vagal trunk and right vagus become posterior vagal trunk. Now in the adults, if you look at the front view, let us pull the stomach from the lever. In that process, you will be pulling the lesser omentum attaching to lesser curvature there. Let us magnify the area now. This lesser omentum, which is attaching to lesser curvature of stomach and the porta hepatis of lever, has two parts. One is called hepatogastric ligament and one is called hepatoduodenal ligament. Hepatoduodenal ligament attached to first part of the duodenum is also called as free margin of the lesser omentum containing the DAV structure. The duct for bile duct, A for hepatic artery and V for portal vein, carried to the porta hepatis of the liver. And the DAV structure will be forming anterior boundary of the epiploic foramen of Winslow, which has the superior boundary of first part of liver or caudate lobe of liver, and the inferior boundary is the first part of the duodenum. Behind the epiploic foramen of Winslow, you will have three structure, that is the T12 vertebra. Along with that, you will have the inferior vena cava posteriorly and also right adrenal gland, which will become clear in the next coming diagrams. But the thing is, you have to take your suction tube here and go behind the stomach for immediate removal of the gastric content in the lesser sac if there was a posterior perforation of gastric ulcer. The content will be behind the stomach in the lesser sac, also called omental bursa. Now this is transverse colon and you are talking about supracolic compartment here. There will be some infracolic compartment discussion as well. Now, as you have operated your patient was supine for a few days and the pus formed in the lesser sac. In supine posture, the pus will come from the lesser sac through foramen of Winslow, enter this hepatorenal pouch of Morrison, because hepatorenal pouch of Morrison is the most dependent location in the supine posture. If you encourage your patient to become ambulatory, sitting standing posture, then the pus will be trickling down into the right paracolic gutter. Let us go to the lower part of the diagram then, which is infracolic compartment. There you will have the rectouterine pouch of Douglas. So you have encouraged your patient to become sitting, standing posture or erect posture, and the gravity will pull the pus into right paracolic gutter so that it can move into what is called as the rectouterine pouch of Douglas if it is a female, or rectovesical pouch in a male. Now there will be a pelvic abscess which can be drained per rectum in case of a male and per vaginum in case of a female. You can do posterior colpotomy, puncture the posterior fornix of vagina, and drain the pelvic abscess from the pouch of Douglas, which is the most dependent location in the erect posture. So as we are suggesting, post-operatively, when the patient was in supine posture, the pus from the lesser sac will be collected into the hepatorenal pouch of Morrison. And as the patient becomes semi-recumbent or erect posture, the pus will be trickling into the rectouterine pouch of Douglas in case of a female, and this pelvic abscess can be drained per vagina. Now let us take a little section of the peritoneal cavity to discuss the lesser sac and greater sac once again. As you can notice, this blue color space which is behind the stomach is called as lesser sac, and this pink color space is all the greater sac, including rectouterine pouch of Douglas, it is greater sac, and hepatorenal pouch of Morrison is greater sac. But the space behind the stomach is lesser sac. As we said, there is a posterior perforation of gastric ulcer. Content were behind the stomach in the lesser sac. We have removed it by passing through the epiploic foramen of Winslow. We go to the anterior abdominal wall, the greater sac, and then enter the lesser sac passing this foramen. It will have some 3 structure anterior and 3 structure posterior. What are the 3 structure anterior? There is a double fold of peritoneum called lesser omentum attaching to lesser curvature of stomach, and also porta hepatis containing DAV structure. Let us magnify this area then. And posteriorly also you will have 3 structure at the level of T12 vertebra. Let us magnify the area here. As you magnify this area, you will see DAV structure which are anterior to the foramen of Winslow. D for duct, bile duct is most anterior, hepatic artery is in the middle, and vein, portal vein is posterior. So DAV, anterior to posterior, in the free margin of lesser omentum. And what are the 3 structure posterior? They are the T12 vertebra and the inferior vena cava along with the right adrenal gland. And superior is L1 and inferior is D1. What is L1? The lever 1, the caudate lobe of lever, is superior boundary of the foramen Winslow, and the D1 is duodenum first part, inferior boundary of the foramen of Winslow. So this is the magnified area which we are looking at. As I was suggesting, this epiploic foramen of Winslow, there is DAV structure running anteriorly in the free margin of lesser omentum, which is also called as hepatoduodenal ligament, because attaching to porta hepatis lever and the first part of duodenum. You can do Pringle's maneuver. Take your finger into the foramen Winslow, pull the DAV structure anterior, and put one artery forceps upon that to minimize bleeding when you are operating on the lever. You can see the duct D, bile duct is most anterior, the A artery is sandwiched in between, and the V vein, portal vein, is the most posterior. Duct, the bile duct is more to the right side, and the artery, hepatic artery, is more to the left side, whereas the vein, portal vein, is posterior to both of them. If you look from the inferior view of the abdomen region, taken a transverse section, you are in the abdomen looking towards the thorax. You can again see this blue space, that is the lesser sac, a small space behind the stomach. Otherwise, this all cavity is the greater sac. As you understand, the patient was having posterior perforation of the gastric ulcer, so content will go behind the stomach in the lesser sac. This is the stomach which has perforated posteriorly, so content came into the lesser sac. If you want to remove them, then you have to enter greater sac and pass through foramen of Winslow to enter lesser sac and remove the content. When you are passing through the foramen of Winslow, there you could see 3 structure anterior and 3 posterior. DAV structure are anterior in the free margin of lesser omentum, a double fold of peritoneum attaching to greater curvature of the stomach. The DAV structure are duct, bile duct, A artery, hepatic artery, V vein, portal vein. Then there are 3 structure posterior also. The T12 vertebra, on that is inferior vena cava and right adrenal gland. This foramen of Winslow is sandwiched between 2 veins, the portal vein anterior and inferior vena cava posterior. You can also notice that this is the spleen projecting into greater sac of the peritoneal cavity, suspended by two ligaments of spleen developing in the dorsal mesentery. This is the splenogastric ligament attaching to greater curvature of the stomach, suspending spleen into greater sac, and also is the splenorenal ligament, which is now related with the left kidney, as the spleen has moved to the left side. This is the abdominal aorta, which was giving splenic artery to spleen, and that was carried by the splenorenal ligament. And that splenic artery was giving some short gastric arteries to the greater curvature of stomach, which were carried by the splenogastric ligament. When we compare the small intestine with the stomach or large intestine, the small intestine will have three specific features. In the small intestine, maybe it is duodenum, jejunum, ileum, we'll find that there is the presence of plicae circularis to increase the surface area of absorption. Number two, they'll have villi, and number three, they'll have microvilli to increase the surface area of absorption. These three things will be missing from the stomach as well as large intestine. Now, these three things are more present in the jejunum as compared with the duodenum or the ileum. So when you talk about the plicae circularis, which are permanent fold here to increase the surface area of absorption, will be most prominent in the middle portion, that is the jejunum. Compared with ileum, ileum will have all the three things going down. Means if you compare the jejunum with ileum, you will find plicae circularis are reducing in number, villi are reducing in number, microvilli are reducing in number. Now, if the three things are reducing in ileum, what are the three things which are increasing in the ileum? And they are, number one, the lymphoid aggregations are more prominent, so much so that in the terminal ileum will have pairs, patches. Number two, what is increasing more towards ileum is fat in the mesentery. And number three, the number of arteries supplying the ileum, the vasa recta or the straight vessels. So three things are more towards the ileum, that is the lymphatic tissue, the fat in mesentery, and the number of blood vessels. If you compare the ileum with the jejunum, you will find the number of blood vessels are less and there is less of fat in the mesentery. And even the lymphatic tissue is less as compared with the ileum. Now, maybe the arteries are less in number, but they are longer in case of jejunum, and here they are shorter vasa recta in case of ileum. One more thing you can notice is the wall of the jejunum is thick and wall of the ileum is thin. Now, when you compare the small intestine with the large intestine, you'll have three things missing and three things present. So what are the three things missing in the large intestine? Large intestine do not have the plicae circularis, no villi, microvilli. And what are the three things present in the large intestine? They are alternate contraction and dilatation of the wall of the large intestine cause the hausturations or sacculation. And number two, there is a longitudinal thickening of the muscles forming some three bands and called as the tinea coli. And number three, it is the appendices epiploicae, peritoneal pouches filled with the fat related with tinea coli. These things will be missing from the small intestine or stomach. The large intestine has 8 parts, which are 4 colons and 4 more. The colon are ascending colon, transverse colon, descending colon, sigmoid colon, and the other 4 parts are the cecum appendix and rectum anal canal. You can notice the hausturian sacculation here. Now, when it comes to tinea coli or the appendices epiploicae, they are present on all the 4 colons, plus they are also present on the cecum. Appendix has no tinea coli or the appendices epiploicae, and so is rectum anal canal. They don't have tinea coli or the appendices epiploicae. One more thing which you can notice is the length of the colon. Ascending colon is 5 inches, descending colon is 10 inches, sigmoid colon is the 15 inches, and the transverse colon is 20 inches. You can see it's a table of 5. 5 ones are 5, ascending colon, 5 twos are 10, the descending colon, 5 threes are 15, the sigmoid colon, and 5 fours are 20, the transverse colon. Or you can remember the shortest segment becomes the longest segment. The shortest segment is the ascending colon and the longest segment is the transverse colon. 5 becomes 20, just to remember the length of the colon. Now this is a diagram which will be magnifying in this area to see the 2 renal veins draining into the inferior vena cava. Since inferior vena cava is to the right side of the midline, it is understood that the left renal vein has to cross the midline of the body to enter the inferior vena cava. Hence, it is longer as compared with the right renal vein. Let us magnify the area then. As you can see, the right renal vein is shorter and left renal vein is longer, crossing the midline of the body to enter inferior vena cava, which is on the right side of the midline. Now, left renal vein is crossing the abdominal aorta anteriorly, but is below the superior mesenteric artery to supply the midgut. Now, this left renal vein can be sandwiched between the two arteries, superior mesenteric artery anterior and the abdominal aorta posterior, leading to nutcracker syndrome. In that case, there will be a backflow towards the kidney, renal hypertension, plus there will be backflow into gonadal vein, leading to the testicular varicocele or ovarian varicocele, and also there will be back pressure towards the adrenal gland. As we have learned earlier, adrenal vein and the gonadal vein drain into left renal vein on the left side. But as you see, the right gonadal vein or the right adrenal vein drain directly into inferior vena cava, as the right renal vein is doing. Let me show you the diagram of nutcracker syndrome now. Here you can see the superior mesenteric artery is compressing the left renal vein upon the abdominal aorta, which is on the posterior side. Because of that, there is dilated, elongated, tortuous vein, varicose veins, especially towards the gonadal veins. There is varicocele seen here, and also there will be back pressure towards the adrenal gland and towards the kidney. This is called nutcracker syndrome, compression of the left renal vein running anterior to abdominal aorta and posterior to the superior mesenteric artery. We also want to know the relation of pancreas and the uncinate process along with the head. It is understood that behind the head of pancreas, the two renal veins drain into inferior vena cava. So there are three veins behind the head of the pancreas, which we have removed from here. Behind the head of pancreas, you have right-left renal vein draining to IVC, whereas behind the uncinate process of pancreas, you have the abdominal aorta lying there. Let us look at a diagram for the same now. So here is the left renal vein, right, draining into inferior vena cava behind the head of pancreas, whereas the uncinate process of pancreas lie in front of the abdominal aorta. Both of the structures are crossing abdominal aorta anteriorly, maybe the left renal vein or the uncinate process of pancreas. In this diagram, we want to see what are the four viscera in front of the right kidney, and then we will also see some viscera in front of the left kidney. Behind the kidney, there is no viscera, but only some ribs and muscles are present. So in front of right kidney, you will see a large organ has been removed, that is the liver, and this is the hepatic area, where you can see hepatorenal pouch of Morrison also. Number 2, it is having the adrenal area for right adrenal gland. Number 3, it is the hepatic flexure of colon or right colic flexure. And number 4, second part of the duodenum. So there are 4 viscera in front of the right kidney. As you come to the left kidney, you will find left kidney is related with the splenic flexure of the colon or left colic fixture anteriorly. It is also related with the body of the pancreas anteriorly and the left adrenal gland anteriorly. This area is called as the gastric area. The left kidney relates with the stomach and right kidney relates with the liver, hepatic area. Then you will notice that tail of pancreas which is going to the hilum of spleen, and spleen is relating with the kidney. Here it is a simplified diagram of the same, which is anterior relation of the right and left kidney. As we have discussed left kidney, this is the spleen area, later with the left kidney anteriorly. This is the adrenal area, the left adrenal gland. This is the gastric area, the stomach. This is the body of the pancreas. And this is the splenic flexure of the colon. Whereas on the right kidney, you have the second part of the duodenum related and the hepatic flexure of the colon. This is the liver area or hepatorenal pouch of Morrison area. And that is the right adrenal area. Now let us see what is behind the kidneys. Because there are no viscera, there will be some muscles, ribs and nerves. As you look at the posterior of the kidneys, you'll find the kidneys ascend from the pelvis into the abdomen region. The right kidney is unable to ascend too high because the liver will prevent that. So the right kidney will be lower and left kidney will be higher. Left kidney is ascending higher and related with the 12th as well as 11th rib, both the ribs, whereas the right kidney is related only with the 12th rib alone. Let us magnify this area now. So this is the posterior view of the left kidney and the right. Right relates with only 12th rib and the left is higher, so it relates with the 11th rib as well. Under the 12th rib, you have subcostal neurovascular bundle. So that will be related to both the kidneys. There are three nerves and three muscles behind each kidney. One of them is subcostal nerve. Then you have the iliohypogastric nerve coming from lumbar plexus and the ilioinguinal nerve from the lumbar plexus. It will be same on the both side. And there are three muscles also behind the kidneys. The most medial is psoas major. In the middle is the quadratus lumborum, and the most lateral is the transversus abdominis muscle of the anterior abdominal wall. These two muscles are on the posterior abdominal wall, whereas the transversus abdominis goes to the anterior abdominal wall. Looking inside the kidney, you will find there is the outer cortex and inner medulla. If you magnify the area, you will find that in the outer cortex, you will find the parts of the nephron, basically the glomerulus, the Bowman's capsule, PCT, DCT, whereas if you're talking about the loop of Henle or the collecting ducts, they'll be running in the medulla. As the nephron is involved in forming urine, which is ultrafiltrate of blood, it will be poured into the collecting duct, and which will be going to the renal papilla, opening into the minor calyx. And from the minor calyx, the urine will go into major calyx and then into renal pelvis, ureter, urinary bladder, and goes out of urethra. As you go into more details of the kidney, you'll find there is outer cortex and inner medulla. But then it is understood that the medulla, which is called as renal pyramid as well, is extending into the cortex. And on the other hand, the cortex is extending in between the medulla. So these are called as renal columns, the cortex extending between the medulla. And these are the medullary rays, which are the medulla extending into the cortex in the periphery. In the cortex, you'll have the parts of the nephron, which is PCT, DCT, whereas the loop of Henle and the collecting ducts are coming into the medulla and putting the urine into the minor calyx, major calyx, renal pelvis, ureter, urinary bladder, and then urethra. Now we want to talk about the relations of the ureter on either side. You will notice some constrictions also are present in the ureter. Let us look at the 5 constrictions of ureter first. The length of ureter is 25 centimeter, 12.5 is abdominal, and 12.5 is the pelvic. The junction is at the pelvic brim, that is the hip bone. Prior to that 12.5 and after that 12.5 centimeter of ureter. The very first constriction is at the pelvic ureter junction. Let us isolate that diagram now. So this is the renal pelvis becoming ureter, and first narrowing of ureter is at the pelvic ureter junction. The calculus can be found here. Number 2, when it is crossing the pelvic brim. When abdominal ureter become pelvic ureter, it is lying in front of the bifurcation of the common iliac artery. It is the artery dividing into external and internal iliac artery, and the ureter passes anterior to that bifurcation. At the pelvic brim, there is a narrowing of ureter. Number 3 narrowing is when it is hooking under the ductus deferens in a male, or it is round ligament of uterus in a female. Let us magnify the area then. And number 4 is the narrowing at the level of ischial spine in radiograph, or where the ureter enters the bladder, which is called ureter vesical junction. This is the nervous lumen of the ureter as per Gray's Anatomy. Some books will say nervous lumen is intramural course when it is passing through the detrusor muscle of urinary bladder, and some books will say it is a trigonal opening. So my advice is nervous lumen according to Gray's Anatomy, ureter vesical junction. If not found, then you can say it is intramural course. If that not found, then you can say trigonal opening is also the narrowest lumen. So total 5 narrowings. One is trigonal opening, one is the ureter vesical junction, one is when you have the ductus deferens or the round ligament of uterus, and one when it is crossing pelvic brim in front of common iliac artery bifurcation, and the very first was pelvic ureter junction. Talking about the relations of the ureter, you have to understand ureter was passing in front of the common iliac artery bifurcation into internal external iliac artery. But when you look at the previous arteries, they will be all passing anterior to the ureter. For example, gonadal vessels cross the ureter, maybe right or left ureter, medial to lateral, coming from abdominal aorta, but running anteriorly to the ureter. Let us isolate this diagram as well. So this is the abdominal aorta, which is giving the gonadal arteries, and gonadal arteries are crossing the ureter anteriorly on the left side as well as right side, and they run medial to lateral. Now the abdominal aorta also gives some branches called colic arteries running medial to lateral, maybe the right colic artery, ileocolic artery, or maybe the left colic artery. These all arteries cross ureter medial to lateral, and they all are present anterior to ureter. Ureter is behind all these vessels. Ureter is also crossed by the root of mesentery, as you remember, but it is root of mesentery crossing only the right ureter because it is present from the midline to the right iliac fossa. It do not cross the left ureter. Left ureter is crossed by the sigmoid mesocolon at the pelvic brim, at the bifurcation of the common iliac artery into external internal iliac artery. These all structures are anterior to the ureters. When it comes to arterial supply of the ureter, you will find wherever the ureter was running, it will receive all the arteries. So instead of remembering which arteries supply the ureter, it's better to remember which is not supplying. And it is external iliac artery. Do not supply the ureter. Otherwise, ureter is supplied by internal iliac artery, of course, and then it is common iliac artery, then it is the abdominal aorta, then it is the gonadal arteries, then it is the renal arteries as well, supplying ureter at various levels. Except one artery, which is external iliac artery, do not supply the ureter because it comes outside and ureter is going deeper into pelvis. Let us look at the relation of the spleen as well, as it is understood that spleen will be in the abdomen region, and it is on the left side related with the rib number 9, 10 and 11. The central axis will be the 10th rib. The spleen will have some visceral relation anteriorly, whereas posteriorly it will be lying on the diaphragm and also the rib number 9, 10, 11. So what are the anterior relations of the spleen? We want to find out which are related. And also you can see that it is not falling into the left paracolic gutter because of a ligament here called as the name accordingly, colon and the diaphragm. So phreniocolic ligament prevents the sagging of the spleen into left paracolic gutter comes as a question. So what about the relations of the spleen with the viscera anteriorly? As we have learned earlier, the tail of the pancreas will be coming to the hilum of the spleen along with the sum of the splenic vessels. The spleen is related with the left kidney also, which is lying inferior, where the stomach will be lying superior. So that will be the gastric area for relating with the stomach, and this is the renal area for the left kidney. And here is the colon area, that is the splenic flexure of the colon. And the ribs, which are lying posteriorly, are 9, 10, 11. The central axis is the 10th rib. Now we talk about some of the arterial supply in the abdomen region. This is the celiac trunk, which is branch of the abdominal aorta, giving 3 branches, namely the common hepatic artery towards the liver and left gastric artery towards the lower esophagus and lesser curvature of stomach, and the splenic artery, which is the largest branch to supply the pancreas and the greater curvature of stomach and also the spleen. Now understand that the celiac trunk, when it gives the common hepatic artery, it is called common because it will bifurcate into 2 branches, and it is called hepatic artery because it is going to supply the liver. So this common hepatic artery, as it bifurcates into 2, the branches are called as proper hepatic artery to the liver, and there is a gastroduodenal artery which is running downward. The proper hepatic artery will go towards the liver and even to right and left hepatic artery, entering the porta hepatis. It is the right hepatic artery which will be giving cystic artery, which is forming the boundary of the Collette's triangle there. Cystic artery on the base and cystic duct on the right side and common hepatic duct on the left side. This is the Collette's triangle. Understand that right and left hepatic artery, both of them will be supplying the caudate lobe of liver. The caudate lobe of liver is the boundary line liver having double artery and double vein and double duct drainage. Now this gastroduodenal artery, which is passing behind the first part of the duodenum, will be giving 2 branches. One is superior pancreaticoduodenal artery supplying the pancreas upper head and the proximal duodenum, whereas the other branch is called as the right gastroepiploic artery. Now this right gastroepiploic artery branch of the gastroduodenal artery will be anastomosing with the left gastroepiploic artery, for which we will be discussing a branch of the splenic artery. And they will be anastomosing on greater curvature of the stomach, supplying greater curvature of stomach, the left gastroepiploic artery and the right gastroepiploic artery. Whereas the superior pancreaticoduodenal artery is anastomosing with inferior pancreaticoduodenal artery branch of the superior mesenteric artery, supplying the midgut. Superior mesenteric artery itself is a branch of the abdominal aorta. So head of pancreas is supplied by superior pancreaticoduodenal artery and inferior pancreaticoduodenal artery, and they are anastomosing on the head of pancreas. Superior pancreaticoduodenal artery will supply the proximal duodenum, the foregut part of the duodenum, whereas the inferior pancreatiduodenal artery will be supplying the distal part of duodenum, that is the midgut part of the duodenum, as it is a branch of the superior mesenteric artery supplying the midgut, whereas the superior pancreatiduodenal artery, this is a branch of gastroduodenal artery, branch of the common hepatic artery, is a branch of celiac trunk, the artery of the foregut. Now this artery of foregut, the celiac trunk, will be giving the splenic artery to the spleen. But it is running on the superior border of the pancreas, hence it is tortuous in nature and giving multiple branches to pancreas. It is also going to supply the greater curvature of stomach by giving short gastric arteries and the long gastric artery. The short gastric arteries are carried by the splenogastric ligament, as we observed earlier, to reach the fundus of the stomach, supply the greater curvature of stomach. Whereas this is the long gastric artery, which is called as left gastroepiploic artery, branch of splenic artery, run along the greater curvature of stomach in the greater omentum and anastomose with the right gastroepiploic artery, which we'll see in the next diagram. You can also see that the splenic artery giving multiple branches in the spleen, and those branches are end arteries. They're called end arteries because once given, they have no further anastomosis within the substance of the spleen. Now let us have some more details of the arterial tree here. As is understood, this is the celiac trunk and is giving left gastric artery. It will supply the lesser curvature of the stomach and also supply lower 1/3 of the esophagus. It passes through the diaphragm at the T10 vertebra along with the esophagus opening. And this is the common hepatic artery, called common because it bifurcates into two. There will be a proper hepatic artery to the liver, and there is a gastroduodenal artery to the duodenum and the stomach. Proper hepatic artery will be divided into right and left hepatic artery, and the right hepatic artery gives the cystic artery to the gallbladder, whereas gastroduodenal artery passes behind the first part of the duodenum. Prone to bleeding if there is a posterior perforation of the duodenal ulcer. Is dividing into two branches. One is called superior pancreatiduodenal artery, supplying the proximal half of the duodenum and upper head of pancreas, whereas this is right gastroepiploic artery running along the greater curvature of the stomach and present inside the greater omentum, attaching to greater curvature of the stomach. In the greater omentum is also the left gastroepiploic artery, branch of the splenic artery. The anastomose on the greater curvature of stomach, supplying the greater curvature of stomach. Now, a splenic artery is a tortuous artery running behind the stomach. It is in the bed of the stomach and is giving short gastric artery to the fundus stomach carried by splenogastric ligament, and it is giving this long gastric artery, which is called left gastroepiploic artery. Now, if we know the veins, they will follow the arteries and have same name almost. We'll see one diagram later. At present, let us look at the branches of superior mesenteric artery and inferior mesenteric artery as well. The superior mesenteric artery, which is the artery of the midgut, will be giving ileocolic artery and the middle colic artery. The ileocolic artery itself will be giving right colic artery. Now, ileocolic artery is supplying the terminal ileum and the colon, ascending colon, whereas the right colic is supplying the ascending colon here, and the middle colic is supplying the transverse colon. The superior mesenteric artery branch of abdominal aorta can supply only till the right 2/3 of the transverse colon till the midgut, because splenic flexure and the rectum part of the hindgut will be supplied by the next artery, which is inferior mesenteric artery, artery of the hindgut. This inferior mesenteric artery is giving left colic artery to supply the descending colon. It is also giving a branch which will supply the splenic flexure of colon, and then it is giving the superior rectal arteries, sigmoidal arteries, to supply the rectum anal canal and also the sigmoid colon. There is a watershed area at the junction of right 2/3 of transverse colon, left 1/3 of transverse colon, because it is supplied by the terminal branches of the middle colic artery and the left colic artery. So this is prone to ischemia, and the first injury will be there. Watershed area is present. There is a watershed area here also, the pseudex critical point, which is having the terminal branches of the superior rectal artery, and from here below comes the branches of the middle rectal artery. So prone to ischemia, being a watershed area again. As we suggested, the veins have same name as the arteries, but not necessarily all the time. You can see a few of them now. There was a left gastric artery, so this is the left gastric vein, and there is splenic artery, so there's a splenic vein. There are a short gastric artery, short gastric vein, long gastric artery, that is left gastroepiploic artery and left gastroepiploic vein, anastomosing in the right gastroepiploic vein. But then there are some differences also. You will notice the hindgut, which drain into the inferior mesenteric vein, joins the splenic vein, and then they are coming behind the neck of pancreas, receiving the vein of the midgut, which is superior mesenteric vein, and Together they form the portal vein, which passes behind the first part of the duodenum and enter the porta hepatis of liver. Portal vein is directly receiving the right gastric vein and the left gastric vein. Understand that the left gastric vein is draining lower esophagus, which is also drained by the systemic veins towards the azygous venous system. So there will be some portal systemic anastomosis here because this is portal venous circulation and that is the systemic venous circulation. And it might open in portal hypertension, leading to esophageal varices and massive hematemesis, vomiting of blood. Let us talk more about that then. But first we need to talk about this area of formation of portal vein. As the spleen is sending the splenic vein, it will be receiving the inferior mesenteric vein, which is the vein of the hindgut, and then they reach here to receive the superior mesenteric vein of the midgut. Behind the neck of the pancreas, you have three veins. At the transpyloric plane, formation of the portal vein. The meeting of splenic vein with superior mesenteric vein to form the portal vein, which will enter the porta hepatis of liver. This inferior mesenteric vein runs in a paraduodenal fossa, and when you are operating on the paraduodenal fossa, be careful not to damage this inferior mesenteric vein in that region. Now, talking about the portal systemic anastomosis in case of portal hypertension, we just mentioned that if it is the hindgut like the upper rectum, drained by the superior rectal vein into the inferior mesenteric vein, the hindgut vein, into the splenic vein, and joined by the superior mesenteric vein, the vein of the midgut, together form the portal vein, which divide into right and left branches at the porta hepatis of the liver, bringing the nutrients into the liver, which will be metabolized, and the metabolites carried by the hepatic veins into the inferior vena cava. This is the normal circulation. But inferior vena cava is systemic circulation and portal vein is portal venous circulation. Now, as you can see, the left gastric vein, which is draining into the portal vein, is having communication with some of the esophageal vein, which drain into the azygous venous system. That is the systemic circulation here, which drain into superior vena cava. Azygous vein drain to superior vena cava. Now, in case of Budd-Chiari syndrome, say for example, there was a hepatic vein thrombosis. So liver could not drain into inferior vena cava. There will be a backflow, reversal of blood flow, portal hypertension. And that blood flow will be coming back into the portal vein, into the left gastric vein, and jump into the esophageal vein, azygous venous system. Now, this communication, portal systemic anastomosis, is quite thin and dilated, elongated, tortuous vein, varicose vein, esophageal varices, and the blood wants to reach the azygous venous system and then the superior vena cava. If the blood could not enter inferior vena cava here, then it would like to enter superior vena cava there, because all veins ultimately want to drain into the heart there. Also, since there is a reversal of blood flow, the blood flow will come back into the portal vein, into splenic vein, into the inferior mesenteric vein, into the rectal vein, which is superior rectal vein, and can jump into the middle and inferior rectal vein. Now, middle inferior rectal vein are systemic venous circulation. They drain into the iliac veins, and iliac veins join to form inferior vena cava. So, if there was an inability of draining into the inferior vena cava at the liver level, the blood was coming back into a portal vein, splitting vein into inferior mesenteric vein and into the superior rectal vein, jumping into middle inferior rectal vein, and then into the iliac vein, and then into inferior vena cava. Ultimately, the blood wants to reach the heart in any case. But in this process, when you see the communication of superior rectal vein and the middle inferior rectal vein, they are thin veins, become dilated, elongated, tortuous, and can bleed, leading to rectal varices. In case of portal hypertension, you can see one more level where we have the portosystemic anastomosis, that is around the umbilicus. It is understood that when there is a portal hypertension, the blood will be reversal blood flow into the left branch of portal vein and towards the para-umbilical veins. Following the ligamentum teres, the blood will come towards the umbilicus region and anastomosing with the systemic veins, which are epigastric veins. Names are inferior epigastric vein and social epigastric vein. So there will be a caput, meant to say, around the umbilicus, and this blood can jump into the systemic veins. Like this is the inferior epigastric vein. The blood will go into the external leg vein, and this is the superficial epigastric vein taking blood towards the great saphenous vein, into the femoral vein, into external leg vein, into common leg vein, and into the inferior vena cava. But that portosystemic anastomosis leads to caput medusae here. Now, to deal with such a situation, you could have done a shunt, which is called TIPS, transjugular intrahepatic. It is a portal systemic stenosis, so that you could drain some of the portal venous blood into the hepatic veins directly and towards the inferior vena cava to deal with the portal hypertension. The abdomen region is divided into 9 quadrants, which are called as the epigastrium and the 2 hypochondrium. There is umbilical region and right and left lumbar region. There is the suprapubic hypogastric region and the right left iliac fossa. You have to draw a midclavicular line which will be coming to the mid-inguinal point here. On the right side as well as left side, the mid-clavicular line running towards the mid-inguinal point here. Also, you can draw the transverse plane, which could be the transpyloric plane at the lower border of L1 vertebra at the tip of the 9th costal cartilage here, or you can use what is called subcostal plane, which is L3 vertebra level to define the umbilical region here. Then there is a transtubercular plane, intertubercular plane, which is lying 5 centimeter behind the anterior superior iliac spine, and it is at the L5 vertebral level. So 9 quadrants are created that way. The spleen lies in the left hypochondrium. Liver lies mostly in the right hypochondrium and also epigastrium, encroaching upon left hypochondrium. The kidneys are in the lumbar region. Appendix is in the right iliac fossa. Let us talk more about the transpyloric plane then, lying at the lower border of L1 vertebra, where you have the pylorus of stomach also, and termination of adult spinal cord. So here is the transpyloric plane. How do you put it? You have to go to the mid-clavicular line, put a line directly down, which is reaching the tip of the 9th costal cartilage, and there you will have the transpyloric plane, the plane where you can see the pylorus of stomach, and also you will notice formation of portal vein behind the neck of pancreas. Also, you will find the abdominal aorta giving supramesenteric artery and the renal arteries. Hence, the hilum of each kidney will also be at the transpyloric plane, since renal arteries are given here. Here we are looking at the development of the genitourinary system, which is developing from intermediate mesoderm. It will be forming some ridges and some of the ducts. As we understand, the urogenital ridge is going to form kidney, testis, or the ovaries, whereas we have got one mesonephric duct, which is also called Wolffian duct, which contributes to the male reproductive tubes, whereas females will have paramesonephric duct, Mullerian duct, contributing to female reproductive tubes. In fact, we are going to have a primordial germ cell, which is itself developing from the epiblast cells. It is the epiblast cells which will form primordial germ cell, which are migratory cells, so they migrate towards the endoderm wall of the yolk sac, and then using the dorsal mesentery of the hindgut, they will come to the region of the gonads, that is reach the urogenital ridge and convert into maybe oocytes or spermatocyte depending upon the sex of the baby. Now, it is understood that if the baby is male, then there will be a Y chromosome, and in the short arm of the Y chromosome, which is actually acrocentric chromosome, you will find a gene which is called as SRY gene. That is the sex region Y chromosome on the short arm of the acrocentric Y chromosome, and it is coding for a protein called testis determining factor. So the baby will have the testis. Testis will start secreting testosterone, that is the Leydig cells will give testosterone, whereas the Sertoli cells will give Mullerian inhibiting factor. So the Mullerian duct will be inhibited in a male, and the male characteristic features will be developing. On the other hand, if we are not having this Y chromosome with the SRY gene, then by default the individual is supposed to become a female with ovaries and the female reproductive system. And regarding the timeline, it is seen that Epiblast will be giving us the primordial germ cell by the end of the second week or beginning of third week. Then they are migrating towards the endodermal wall of yolk sac. They will be reaching the genital ridge by week number 5. So by week number 5, the genital ridge has appeared, and by week number 6, we will have in different gonad. Means the sex determination is not possible till week number 6. It is only at week number 7 that the testes start developing, and we can tell that it is a male or a female, though the ovaries start developing a bit later, and it will be around 8 to 10 weeks of development. So the timeline is that the epiblast will form primordial germ cell by second and third week, whereas they are reaching the genital ridge by week number 5, which the ridge will also appear at the same time. And then till the week number 6, it is in different gonad. The testes start developing at week number 7. The ovaries are a bit delayed in development, that is week number 8 to 10. And it will take at least week number 11 to week number 14, so that the external genitalia are well differentiated, which can be used ultrasonographically for sex determination. In sex determination, you have to look at the external genitalia. For example, the scrotal shadow will go in favor of the male. This intermediate mesoderm is going to contribute to genitourinary system, as we see that it is going to form pronephros, mesonephros and metanephros as well. But the pronephros and mesonephros disappear in the humans. It is the metanephros which is going to form the kidney. But kidneys do not develop just like that. They need stimulation, and for that stimulation, what we have is mesonephros disappearing, leaving behind one mesonephric duct on each side, right and left side, and they are going to give us what is called as ureteric bud. That ureteric bud which comes from the mesonephric duct will be going to stimulate the metanephros to change it into metanephric blastema, and metanephric blastema is going to form the kidney, whereas the ureter will be coming from the ureteric bud or the mesonephros duct, and the bladder comes from the endoderm of urogenital sinus. Now, as we say, the endoderm of urogenital sinus is going to form urinary bladder and urethra, but not the trigone, because the trigone is formed by mesoderm. In fact, what happens is tip of the mesonephric duct will be absorbed into the posterior wall of the urogenital sinus to form the trigone. Hence, the trigone is mesodermal in origin. Here we're looking at the side view of the developing baby, and you can again see pronephros, mesonephros, metanephros, which should have come from the intermediate mesoderm. But as we know, the pronephros and mesonephros are disappearing. Mesonephros will leave behind a duct on each side, that is the mesonephric duct is important because it is the one which is going to give us the ureteric bud. That ureteric bud is going to penetrate the metanephros, and then only the metanephros is going to form metanephric blastema and the kidney. Kidney has two portions. One is involved in urine formation, that is the excretory system, which will come from the metanephros. But if you are talking about the collecting system of the urine, that is by the ureteric bud derivative. We will be discussing 5 derivatives of the ureteric bud, which will be collecting the urine and taking it towards the urinary bladder and passing it out of the urethra. When it comes to urinary bladder, urethra, it is coming from the endoderm of the urogenital sinus, except the trigone, because the trigone was formed by the absorption of the tip of the mesonephric duct on the posterior wall of the urogenital sinus there. Now let us look at the two parts of the kidney in the next diagram. Here we will understand that metanephric blastema is going to form nephron, which is having several components concerned with the formation of urine. But then the urine must be collected by the collecting system. These are the 5 derivatives of the ureteric bud. The urine will be collected by the collecting ducts into the major calyx and then renal pelvis and then moving into the ureter. Let us look at a table which will tell us about the 5 derivatives of ureteric bud again, and also the parts of the nephron coming from metanephric blastema. So here the metanephric blastema would have formed the nephron, which contains the renal glomerulus and also the Bowman's capsule, PCD-DCD loop of Henle, as well as the connecting tubule, all coming from metanephric blastema. When it comes to mesonephros or the mesonephric duct, the ureteric bud was given, and it will be forming the 5 derivatives which we already have mentioned: the collecting duct, minor, major calyx, and the renal pelvis and the ureter, which we have seen in the diagram as well. Now, as we said that in week 5 to 6, it is indeterminate embryo and the sex determination is not possible. What we have got is the genital ridge, which might become a testis or ovary depending upon the presence or absence of the Y chromosome there. And then we have the mesonephric duct here, which is one on each side, and also on the side of that we have the para-mesonephric duct, the other name of the Mullerian duct. Actually, the Mullerian duct are two on right and left side. They fuse in the midline, and then there's one midline opening on the dorsal wall of urogenital sinus, whereas there are two lateral openings also for the mesonephric duct, one on each side. So there are three openings in the urogenital sinus, which is itself going to form urinary bladder and the urethra coming from the endodermal origin, whereas the ridge and the two ducts are from the intermediate mesoderm. Now, as we talk about a male, that is week number 7 onwards, we'll find that the gonads are changing into the testes. Testes will form the sperm, and you need a collecting system for sperm, which will be coming from the mesonephric duct, which is also called the Wolffian duct. The mesonephric duct or Wolffian duct will be giving us the epididymis and the ductus deferens, and also the seminal vesicle and common ejaculatory duct, which will be ejaculating the semen into the prostatic urethra. That semen can go out through the urethra then. If we are talking about the storage of the semen or the motility of the sperm, or it is the maturity of the sperm, will be happening in the epididymis, which will continue into ductus deferens as well. But the first answer should always be epididymis. And what happens to the Mullerian duct, which is the paramesonephric duct? Actually, it will be giving us some vestigial remnant. For example, you will have an appendix of testis at the cranial end, and at the caudal end you will find there is the male uterus, which has become small, or the prostatic utricle opening into the dorsal wall of the urogenital sinus. There are three openings which can be seen in the adult male as verumontanum or seminal colliculus on the posterior wall of the prostatic urethra. And when it comes to female, it will be taking a bit delayed development, that is 8 to 10 weeks. And as you see what happens to the gonadal ridge, they become the ovaries. Ovaries will be undergoing ovulation and giving the secondary oocyte, which will be taken by the fallopian tube. This is the fallopian tube which will carry the fertilized oocyte towards the uterus, and then it will be implanting into the uterus here. As we understand, the fallopian tube and the uterus, upper 1/3 of vagina, come from the Mullerian duct. There are three derivatives of the Mullerian duct. Here, the fused part become uterus and upper 1/3 of vagina, whereas the unfused part will remain as the fallopian tube. As it comes to the lower 2/3 of vagina, it is developing from endoderm of urogenital sinus along with the urinary bladder and the urethra. And what about the mesonephric duct? Mesonephric duct is disappearing, leaving behind what is called as epioophoron and the paraoophoron, and also the Gardner's duct, which can be found in the anterolateral wall of the vagina. It can also be seen in the broad ligament as well. In the discussion of external genitalia, in the beginning there is indeterminate embryo and everything appears similar, but later the genital tubercle in case of female will be contributing to the clitoris, whereas in case of a male will be forming the glans penis. In case of a female, the genital swelling, or called as labioscrotal swelling, will be contributing to the labia majora on the periphery, and in case of a male, it will be forming the scrotum, as the name suggests, labioscrotal swelling. When it comes to urethral fold, which is also called genital fold, in case of a female, it is contributing to labia minora, the inner lip hair around the vagina. And in case of a male, it will go form the ventral portion of the penile urethra. It is also contributing to penile scrotal raphe in the midline. As we revise the development of the genital system, you can see that it is the genital ridge in case of female, forming ovary; in case of male, it is testis. And the primordial germ cell form the oocyte in female and the spermatozoa in male. When it comes to mesonephric tubule or ducts, in case of a female, it is going to form the vestigial remnant, epioophoron, paraoophoron, Gardner's duct, because it is functional only in the male to contribute to the collecting system of the sperm. Basically, the epididymis, ductus deferens, and seminal vesicle, ejaculatory ducts, etc. In case of a female, it is the paramesonephric duct or the mammalian duct which is working, which if fused will form uterus and unfused part form the fallopian tube. Even the upper 1/3 of vagina come from the paramesonephric duct. In case of a male, it will be vestigial to contributing for the male uterus or prostate utricle and the appendix of the testis as well. And it is the urogenital sinus which is going to form urinary bladder and urethra and also lower 2/3 of the vagina, both in case of female as well as the male. Urogenital sinus also form the inner glandular portion of the prostate gland in a male, which is endodermal in origin. Now, regarding the genital tubercle, in the external genitalia, we found clitoris in female and males have glans penis. The urogenital folds are going to form labia minor in female, and it is the floor of the penile urethra in male along with penile scrotal raphe. And if it is the labioscrotal swelling, genital swelling, then in female it is labia majora, whereas male will have the scrotum developing from there. Here we are looking at the front view of a female taken a coronal section to show the two regions which are called as the pelvis and the perineum. The boundary line between the two is the pelvic diaphragm, chiefly constituted by levator and eye muscle there. In the pelvis we'll have the pelvic viscera, that could be the urinary bladder, behind that is uterus, behind that is the rectum, and in the perineum there will be opening of the viscera. For example, the urinary bladder will open as urethra in the perineum, the uterus will open as vagina in the perineum, and the rectum will be opening as the anus in the perineum. Let us go to the deeper details now. As we are looking at the deeper details of the front view of a female, you can find the lateral pelvic wall is giving the muscle which is called as levator and eye muscle, called so because it can elevate the anus in case you are contracting it, and is constituting the pelvic diaphragm, boundary line between the pelvis and the perineum. In the pelvis, we have the pelvic viscera, which could be the rectum opening as the anus in the perineum, or it could be the uterus opening as vagina in the perineum, or it could be the urinary bladder in the pelvis and opening as urethra in the perineum. The pelvic diaphragm is serving as a boundary line between the pelvis and perineum, and also is pelvic viscera support. When you talk about the pelvic viscera support, remember three important pelvic viscera support. One is the pelvic diaphragm, and the other is the urogenital diaphragm, and number three, it is the perineal body. Perineal body will be a central perineal tendon where all the perineal muscles are getting inserted. Let us talk about the importance of perineal body now. As I suggested, that perineal body is a central perineal tendon, and many muscles insert into the perineal body, like it is the levator and eye muscle fibers getting inserted. While we are performing vaginal delivery, we have to support the perineal body. Otherwise, if there is a perineal body rupture, there will be problems like pelvic viscera loses the support and may prolapse down. So perineal body tear may lead to prolapse of the uterus, which is called as uterocele, or the urinary bladder coming down, the vesicocele, or the rectum coming down, rectocele. You must be careful about the support to the perineal body, which itself is supporting the pelvic diaphragm and also the urogenital diaphragm by providing insertion of the various muscles. Let us talk about the urogenital diaphragm as well now, which will be lying at a lower level. So here again is the urinary bladder, and the urethra is passing towards the perineum. This is the pelvic diaphragm constituted by levator and eye muscle, plus there will be one more muscle to discuss contributing to pelvic diaphragm. When it comes to urogenital diaphragm, which is a pelvic viscera support, it is at a lower level, and it is having some muscles inside. Like one of them is sphincter urethra. It's a skeletal muscle to control the flow of urine at our own will, giving urinary continence to the person. In urogenital diaphragm, you have one more muscle which is called deep transverse perineal muscle, called so because it is present in the deep perineal pouch. In the perineum, there are two pouches actually when you approach from below upwards, that is, while you dissect, you are removing the skin and fascia, you reach the social perineal pouch, and then you reach the deep perineal pouch. So there are two pouches in the perineum, and this is the deep perineal pouch where we have got the urogenital diaphragm. This urethra, which we see here coming from the urinary bladder, is passing through pelvis and then in the deep perineal pouch and also the social perineal pouch to open into the perineum. Let us go into more details of the two perineal pouches now. This is again the front view of a female, and we have started dissection. As you dissect, the very first structure we reach is the skin, and as you remove the skin, you will get the colles fascia. As you remove the colles fascia, you can enter the social perineal pouch. There you will have some muscles, like there is bulbospongiosus muscle around the bulb of the vagina. As you go deeper, there will be a perineal membrane, and as you go through the perineal membrane, you will find you have entered the deep perineal pouch. In the deep perineal pouch, we'll have the urogenital diaphragm constituted by two muscles, external urethral sphincter, which also work like a vaginal sphincter, and then DTP muscle, that is deep transverse perineal muscle in the deep perineal pouch. As you go still deeper, you'll find this is the levator ani muscle making the pelvic diaphragm. And if you go still deeper, then you have the pelvic viscera. Like here, it is a uterus giving the vagina. Vagina passes through the pelvis region, the deep perineal pouch, and also superficial perineal pouch to open into the vestibule. And the vestibule is a space where you have opening of the vagina and the urethra. Vagina opens in the vestibule bounded by the two labia minora and below the membrane called as the hymen, which is partially covering the vaginal introitus. You also need to discuss a space here in relation to the rectum and anal canal, which is called ischiorectal fossa, seen on the either side. Levator ani muscle is going to form medial boundary of the ischiorectal fossa. And which muscle is the lateral boundary? That will be the obturator internus muscle on the ischium part of the hip bone. So let us look at the obturator internus muscle, lateral wall, and levator ani, the medial wall of the ischiorectal fossa in the next diagram. Here is the ischiorectal fossa. As you can see, it is having a lateral boundary of the obturator internus covered by some fascia and attaching to the ischium part of hip bone. And it is going to have a medial boundary of the levator ani muscle, as you can see on the other side also. Levator ani, the medial boundary, obturator internus is the lateral boundary, covered by obturator fascia having a canal which is called as the Alcock's canal or the pudendal canal. Now, this pudendal canal is formed in the obturator fascia and contains the pudendal nerve, internal pudendal vessels as well. It is called ischiorectal fossa because lies between the ischium bone laterally and rectum medially. What you see here is not the rectum but the urinary bladder giving the urethra. But in the similar way, there will be rectum giving the anal canal inferiorly. Now, as we have seen earlier, this is the levator ani muscle, which is the deepermost muscle forming the pelvic diaphragm and is a good support of pelvic viscera. Like here, it is supporting the prostate gland and the urinary bladder in a case of a male. There is one more support of the pelvic viscera, which is called urogenital diaphragm, which is present in the deep perineal pouch and having a DTP muscle, which is deep transverse perineal muscle, and also external urethral sphincter, which is a sphincter for the control of the urine at your will. If we go slightly below, then we'll have superficial perineal pouch having some muscles like this is the bulbospongiosus muscle around the bulb of the penis. There are other muscles also like ischiocavernosus, which is lateral muscle. Do not come to the midline. And the most superficial structure will be skin, under which we have the Colles fascia. Colles fascia is the floor of the social perineal pouch. And then what is the roof? Roof is the perineal membrane. Perineal membrane, which is the roof of the social perineal pouch, is also the floor of the deep perineal pouch. It's a boundary line between the two pouches. Below that is social perineal pouch. Above that is the deep perineal pouch. And it is the boundary line, the perineal membrane. It is also called as inferior fascia of the urogenital diaphragm. There is a superior fascia of the urogenital diaphragm as well. Now here we are looking at the front view of the male urinary bladder and the urethra, and we are going to focus upon urinary bladder and the prostatic urethra right now. Let us magnify the region. As you observe that the urinary bladder is meant to accommodate large quantities of urine, so it must be having mucosal fold, and they are called as erugae, which are actually missing from the trigone, which is having smooth mucosa. It is because that in this region of the trigone there is no submucosa, and the mucosa is tightly adherent to the underlying muscle called as the detrusor. So it gives a smooth appearance, and while in case of the rest of the urinary bladder, there is the mucosa loosely adherent to the deep muscle detrusor due to presence of submucosa, allowing the stretching of the mucosa to accommodate large quantities of urine in the urinary bladder. Now, this trigone of urinary bladder is inserted onto the posterior wall of the prostatic urethra, called as the urethral crest, and there is also a rounded elevation called as seminal colliculus on the posterior wall of the prostatic urethra. We'll be looking at that by magnifying this region, but here you can see that there are evident two lateral lobes of the prostate in a coronal section of the prostate from the front view. We also need to discuss the two sphincters of the urethra here, and that can be discussed by magnifying this diagram still further. So as you can see, this is the midline elevation on the posterior wall of the prostatic urethra called as the urethral crest, and it is the insertion of the trigone of the urinary bladder into the urethra. There is the seminal colliculus or the verumontanum having the three opening, which is embryologically you have seen earlier in the dorsal wall of urogenital sinus. There is a midline fused Müllerian duct which is working for a female, because in male it is vestigial and forming the opening of the prostate utricle. The duct which work for a male will be the Wolffian duct, which will be forming the ductus deferens and which continue as the common ejaculatory duct to bring the semen under the sympathetic system here. And then the semen will be ejaculated outside through the urethra. These are the two lateral lobes of the prostate gland as evident in a coronal section of prostate and the front view. The semen which is coming here has a tendency to enter the urinary bladder, which should be prevented, and there is a smooth muscle sphincter, internal urethral sphincter, which is well developed in males, poorly developed in female, controlled by L1 sympathetic fiber, preventing retrograde ejaculation of semen into the urinary bladder. While doing lumbar sympathectomy, it is advisable not to cut the L1 sympathetic fiber. Otherwise, the sphincter will be paralyzed and leads to retrograde ejaculation of the semen into bladder. Now we have one more sphincter, which is external urethral sphincter, which is a skeletal muscle sphincter, which can help us to hold urine at our own will. It is present in the deep perineal pouch having a floor of the perineal membrane, and this muscle contributes to urogenital diaphragm, which is in the deep pouch having a floor of perineal membrane itself. This external sphincter controlled by the pudendal nerve, which is a somatic nerve to control skeletal muscles and helping us to hold the urine. If you give a pudendal block, then the sphincter will be paralyzed and there will be urinary incontinence. Patient cannot hold the urine at their own will. Now, let us look at the sagittal section of the prostate gland then. Here is a sagittal section of the male pelvis, and we are going to focus upon the sagittal section of the prostate gland. Let us magnify the area then. This is the urinary bladder, and the male urethra has three parts as understood. If it is passing through prostate, it is prostatic urethra. Passing through deep perineal pouch, it is membranous urethra. And then passing through the penis, it is the penile urethra. And we are going to focus upon the prostatic urethra now. So this is the sagittal section of the prostate gland. Will have some lobes, like this is the anterior lobe of the prostate, this is the medial lobe of the prostate, and there is the posterior lobe of the prostate. Posterior lobe of prostate is prone to cancer. Medial lobe of prostate is prone to BPH, benign prostatic hypertrophy, leading to bladder outlet obstruction. And anterior lobe is having minimal pathology detected. This is the urinary bladder sending urine into the prostatic urethra, which will then become membranous urethra, passing through deep perineal pouch and then enter the social perineal pouch, where it will become spongy urethra below the perineal membrane there, the boundary line between the deep pouch and the social pouch. This is the common ejaculatory duct which brings the semen into the posterior wall of the prostatic urethra. That is the seminal vesicle adding some content of the semen, and that is the ductus deferens, which brings the semen and the sperm from the testicles in the scrotum. Now let us look at a case of BPH. This is an elderly patient presenting to us with the retention of urine or incomplete evacuation of urine. There is a bladder outlet obstruction because there is a medial lobe hypertrophy called as benign prostatic hypertrophy, and a tongue-like projection is going into the urinary bladder called as uvula vesicae. And because of that, there is a bladder outlet obstruction. The urine cannot evacuate completely. Now, we have to remove this obstruction, and we can put an instrument through the urethra called transurethral resection of the prostate. But when you do that, you are going to compromise the internal urethral sphincter, which is also called sphincter vesicae, and if that happens, there will be removal of the obstruction, of course, but there will be one problem, that common ejaculatory duct which bring the semen, some of the semen might enter the urinary bladder, which is called retrograde ejaculation of the semen, because internal urethral sphincter has been compromised. That happens in more than 90% of the cases post-TURP. Now here are the simplistic way of telling about prostate, the lobes, but then there is a more detailed description of the prostate, and that is the zones of the prostate. Let us look into that detailed diagram then. Understand that there is a periurethral zone which is also called transition zone and prone to the BPH leading to bladder outlet obstruction. And then there is a peripheral zone which is prone to the cancer. Then there are the zones like anterior muscular zone, which is fibromuscular stroma, and usually detected with no pathology as such. And then there's a central zone also, which is again presenting with minimal pathology. So our focus usually remains on the peripheral zone because it is prone to cancer, and the parietal zone because it is prone to BPH. Here we want to discuss the details of the male urethra now, and the length of the male urethra is approximately 20 centimeter. 4 centimeter is the prostatic urethra, around 2.5 centimeter is the membranous urethra in the deep anal pouch, and then there is 15 centimeter of the penile urethra. Most of the male urethra is lined by the stratified columnar epithelium, except at the beginning and the ending. The beginning proximal half of the prostatic urethra has the same epithelium as the urinary bladder, which is transitional epithelium, whereas the opening, as a rule says, any external opening should be lined by the stratified squamous epithelium. So it is non-keratinized stratified squamous epithelium only at the tip of the male urethra. Otherwise, most of the male urethra is stratified columnar epithelium, including the membranous urethra, which is in the deep anal pouch. Now understand, the narrowest lumen of the male urethra is external urethral meatus, and the second narrowest is the membranous urethra in the deep anal pouch. And the widest urethra is the bulbous urethra, and the second widest will be the prostatic urethra. These are all questions. The least dilatable is the membranous urethra, and the most dilatable is the prostatic urethra. Let us look at that details again in front view of the male urethra. So as we suggested, the length of the male urethra is 15 centimeter if it is penile, and if it is the membranous urethra, then it is 2.5 centimeter. If it is a prostatic urethra, then it is the 4 centimeter, total 20 centimeter approximately. Now the prostatic urethra is the second widest urethra. Then which is the widest urethra? That is the bulbous urethra. And which is the narrowest lumen? Narrowest lumen is the external urethral meatus, whereas the second nearest will be the membranous urethra. And it is the membranous urethra which is least dilatable, and the most dilatable is the prostatic urethra, here as it is mentioned. If you take a transverse section of the prostatic urethra, it will appear crescent shape, comes as a question. What is the use of knowing all those details, that what is the length of the urethra, where it is the widest, narrowest, or the most dilatable, least dilatable? It is because when you are putting Foley's catheter, or when you are putting the bougies to break up the fibrous adhesions, which might develop post-operative procedures. So you should know the length and the size of the lumen as well. Now here we have put a female in lithotomy position to discuss the dissection layers, like you have to remove the skin, then fascia, then you get the social penile pouch, then you get the deep penile pouch, then you get the pelvic diaphragm, and then deeper will be the pelvic viscera structures. As we have discussed it earlier, inferior to superior, it is the same approach which we are going to take. Actually, in the exam, you are finding sometimes the examiner give you the coronal section, sometimes they give you the dissection approach, or sometimes it is the sagittal sections as well. So we need to orient ourselves properly. Earlier, we were dissecting from inferior to superior, and we could see the most superficial thing will be the skin and the Colles fascia. So as you start dissecting, you will find the very first thing is skin and social fascia, Colles fascia. As you remove the Colles fascia, you will enter the social penile pouch having some muscles, and those muscles around the bulb of vagina, bulbospongiosus, then there is ischiocavernosus, and this is STP, superficial transverse perineal muscle. So they will be all found in the social perineal pouch. Deep to that will be the perineal membrane, and as you remove the perineal membrane, you will enter the deep perineal pouch, where you will have the DDP muscle and the external urethral sphincter muscle. So similarly, as you remove these muscles in the social pouch, you will go into the deep pouch, and there you will have DDP muscle and the external urethral sphincter. If you remove that also, then deeper most muscle will be the levator ani muscle, and it is making the pelvic diaphragm. So here, the deepermost muscle will be the levator ani muscle. Pelvic diaphragm is contributed by this muscle, and if you go still deeper, then you will have the pelvic viscera. So this orientation you already have. Let us use that on this particular diagram then. So as we start dissecting, the very first thing to remove is skin. Deep to that will be the Colles fascia. As you remove the Colles fascia, you enter the social perineal pouch having some muscles. Like this is the bulbospongiosus muscle. in the social perineal pouch along with the ischiocavernosus muscle, and this is the STP muscle, social transverse perineal muscle in the social perineal pouch. These muscles are supposed to insert into common perineal tendon, central perineal tendon, and it is a midline tendon, receiving the insertion of muscles in the social pouch, deep pouch, and also the fibers of levator ani muscle. But one muscle which you can see, ischiocavernosus, is a lateral muscle, do not come to the midline, so will not be inserted into the perineal body. This perineal body is important while we are conducting the vaginal delivery. The head of the baby is passing through the vaginal introitus, and you must give episiotomy to enlarge the vaginal introitus. Otherwise, there will be perineal body laceration, and that will lead to loss of support of various muscles, and it can be further leading to prolapse of the pelvic viscera. The uterus will come out here, the uterocele, the bladder will come out here, vesicocele, and the rectum can come out as the rectocele. So it is all prevented by this perineal body, a central perineal tendon. Now, as you remove these muscles in the social perineal pouch, you will see a triangular membrane, which is the perineal membrane. If you remove that perineal membrane also, deep to that is deep perineal pouch having DTP muscle, the deep transverse perineal muscle, and along with that you will have external urethral sphincter as well. So there are two muscles in the deep perineal pouch making urogenital diaphragm. If you remove that deep perineal pouch component also, then you will go still deeper and you will have the levator ani muscle, which can elevate the anus here and is making the pelvic diaphragm, the deepermost muscular structure, a pelvic visceral support, fibers inserted into the perineal body there, lying between the vagina anterior and the anus posterior. And if you remove this pelvic diaphragm also, then still deeper will be the pelvis, and you will find the pelvic viscera, the most deeper structures. Now here we have the ischiorectal fossa we were discussing earlier also. Between the ischium bone laterally here, the ischial tuberosity, and here you have the anus and the rectum. So it is called ischioanal fossa, and if you go still deeper, it will be called ischiorectal fossa. The ischiorectal fossa is having a medial muscle, which is the levator ani muscle, and lateral muscle, which is the obturator internus muscle, inserted on the ischium part of the hip bone. One ischiorectal fossa is communicating with other ischiorectal fossa through a horseshoe-shaped communication passing behind the anal canal, and any abscess in one ischiorectal fossa can reach the other ischiorectal fossa, passing posterior to the anal canal there. This ischiorectal fossa has the posterior boundary of the gluteus maximus muscle, which is taking origin from the sacrum bone here and the ischium bone here. So it is called the ischial tuberosity. Sacrotuberous ligament is also present posteriorly along with the gluteus maximus, taking origin from there, the posterior boundary of the ischiorectal fossa. Anteriorly, you have the STP muscle and the membrane, which is called perineal membrane. We have earlier talked about the ischiorectal fossa, as we have discussed that ischiorectal fossa will be having the lateral muscle, the obturator internus muscle, and the medial muscle, which is the levator ani muscle. And in the lateral wall, we will have the obturator internus with the obturator fascia. In that, there will be a Alcock's canal or the pudendal canal having the pudendal nerve and internal pudendal vessels. So that will be here. You'll have the obturator internus muscle with the obturator fascia. There you have the Alcock's canal or pudendal canal, and also internal pudendal vessels giving some branches towards the inferior rectum and the anal canal. Those branches are called inferior rectal nerve and inferior rectal artery, inferior rectal vein, and they become content of the ischiorectal fossa, along with some fibrofatty tissue here. The inferior rectal nerve, which is a branch of the pudendal nerve, passing through ischiorectal fossa, is a somatic nerve to carry the pain of the external anal canal. For example, if there are external hemorrhoids, then they are very painful while they bleed, and that the pain, somatic pain, is carried by a branch of the pudendal nerve called inferior rectal nerve. Now we want to look at the pelvic diaphragm in more detail, but that view will be a different view. It is going to be a superior to inferior view. This is a female lying here. The head is towards your side and the feet are away from you, and you're looking from superior view of the pelvic cavity. So it is understood that anteriorly will be the pubis bone and posteriorly will be the sacrum coccyx bone, and laterally will be ilium and the ischium bone. Now we see that the pubis bone, ilium and the ischium bone give one muscle each towards the coccyx bone, and there are three parts of the pelvic diaphragm to discuss: pubococcygeus muscle, iliococcygeus muscle, and the ischio-coccygeus muscle, making the pelvic diaphragm a pelvic viscera support to support the pelvic viscera. This is a superior view of the pelvic diaphragm here. Let us look at the schematic diagram for this particular area now. So as we can see, the most anterior bone is the pubic bone, and the most posterior bone is the sacrum and the coccyx bone. Here is the sacrum, that is the coccyx bone. Otherwise, this is the ilium and the ischium bone. Now, hip bone has three parts, each giving one muscle towards the coccyx bone, anococcygeal raphe here in the midline, between the coccyx bone and the anus opening. Since it is a female, there will be three openings: anus, and in front of that is vagina, in front of that is the urethra. So what are the three muscles contributing to the pelvic diaphragm? Coming from three parts of the hip bone towards the coccyx bone. You will see this is pubis bone giving a pubococcygeus muscle. This is the ilium bone giving iliococcygeus muscle. And then this is ischium giving the ischio-coccygeus muscle there, here. Now understand that the first two, that is the pubococcygeus muscle and the iliococcygeus muscle, together they are going to elevate the anus, only the first two. So first two will be making the levator ani muscle. In the levator ani muscle, you don't include the ischio-coccygeus muscle. So ischio-coccygeus muscle is not a part of the levator ani muscle, though it is a part of the pelvic diaphragm. Now let us look at the three sphincters of the three opening in the female perineum. And they are a component of the pubococcygeus muscle itself. The names are pubourethralis around the urethra, pubovaginalis around the vagina, and puborectalis around the rectum. Pubourethralis will help us to hold the urine at our own will. Pubovaginalis will help us to hold the vaginal content, and puborectalis will give us the rectal continence to hold the fecal matter at our own will. All these three sphincters are component of the pubococcygeus muscle itself, part of the levator ani muscle, part of the pelvic diaphragm as such. As I suggested, the examiner can give you a sagittal section as well, and we have taken a sagittal section of a female pelvis now. As it is understood, the abdominal wall is covered by the parietal peritoneum, which is going to become the visceral peritoneum. Here it is covering the fundus of the urinary bladder, and it is the parietal peritoneum becoming visceral peritoneum over the uterus, and also it is covering the upper part of the rectum, then go on to the posterior abdominal wall, again become parietal peritoneum. Now see, only the fundus of bladder and the uterus and the upper rectum will be covered by the visceral peritoneum and not the rest of the urinary bladder or urethra. They are subperitoneal structure not covered by peritoneum. So is the vagina and the lower rectum. So lower rectum or the vagina or the lower part of bladder urethra, they are not covered by the peritoneum or subperitoneal structures. As you see, this is the apex of the urinary bladder, and behind this bone called as the pubic bone. This will be the bladder having urine sent out through the urethra, which is in female is only short length 4 centimeter, and most of the length it is lined by the stratified squamous epithelium as it is opening exteriorly into the vestibule of the female perineum immediately. It is passing through the deep perineal pouch and then enter the social perineal pouch and then open into the perineum. Behind that is the uterus and continuous with the vagina, which itself is a long tube, and passing through the deep perineal pouch and then passing through the social perineal pouch to open into the vestibule of the female perineum. We can do what is called as the posterior colpotomy by puncturing the posterior fornix of vagina if we have some collection of pus here, that is a pelvic abscess in a recto-uterine pouch of Douglas. This is the rectum, this is the uterus. Recto-uterine pouch of Douglas is the most dependent location in a female in erect posture, which could be sitting, standing posture, and that pelvic abscess can be drained by posterior colpotomy by puncturing the posterior fornix of the vagina, and the pus can be drained through the vagina. You can find the vagina was passing through the deep perineal pouch along with the urethra, and we need to magnify this area now. And here also you can see that is the perineal body attaching to the perineal membrane posteriorly. It's a central perineal tendon receiving the insertion of many perineal muscle posteriorly. So let us zoom this area now. Here again is the apex of the urinary bladder, and that is the urethra, short length urethra, 4 centimeter, and a tube passing through the deep perineal pouch and also the social perineal pouch, having a boundary line of perineal membrane. Perineal membrane is actually the floor of the deep perineal pouch, and this perineal membrane is also the roof of the social perineal pouch. Passing along with the urethra is also the vagina. Both of them are going to puncture the perineal membrane so that they can come from the deep perineal pouch into social perineal pouch and open into the perineum in the vestibule of the female perineum. Now, in the deep perineal pouch, you have the external urethral sphincter, which is a skeletal muscle sphincter to hold the urine at our own will, controlled by the pudendal nerve, is sending some fibers around the vagina also. So it works like a urethra-vagina sphincter. You can use it to hold the vaginal content also. Both are part of the same sphincter, external sphincter, content of the deep perineal pouch, and a part of the urogenital diaphragm as such. In the social perineal pouch, you can see there's a great vestibular gland of the Bartholin, and the duct is also opening in the superficial perineal pouch. In the beginning, the duct is lined by the stratified cuboidal epithelium, but at the opening, like any other opening, should be lined by stratified squamous epithelium. Same as the vaginal epithelium, as well as the urethra epithelium, non-keratinized stratified squamous epithelium. Now what we are looking at is the sagittal section of the male pelvis, and you can repeat the same information as we did in a female, that there is a parietal peritoneum on the anterior abdominal wall, reflecting onto the fundus of urinary bladder, becoming visceral peritoneum. Then the males do not have uterus, so directly it will be reflecting onto the rectum and making a pouch here, which is called as the rectovesical pouch. Let us look at a schematic diagram of this now. So this is the parietal peritoneum on the anterior abdominal wall and becoming visceral peritoneum on the fundus of urinary bladder. Then it is making a pouch here, which is called as the rectovesical pouch. In male, there can be collection of the pus hair, and that is the most dependent location in a male, that is the rectovesical pouch. And if you want to drain the pelvic abscess, then you have to drain it per rectum. The pus can be drained per rectum in a male by puncturing this pouch here. You'll find that there is a fascia which is lying between the rectum posterior and the prostate anterior. This is the fascia of the Denon Villiers. And you can also see one more fascia which is lying behind the rectum and in front of the sacrum, and that is called as the Waldeyer's fascia. And here is the urinary bladder giving us the prostatic urethra passing through prostate. This is the membranous urethra passing through the deep perineal pouch, and this is the penile urethra going to enter the penis. This is the perineal membrane, and attaching posterior to the perineal membrane is the perineal body, central perineal tendon. Let us look at more details of this diagram now. As this is the apex of the urinary bladder, shown anteriorly, this is the sagittal section of the prostate gland and prostatic urethra. Then it is the membranous urethra passing to the deep perineal pouch and becomes the spongy urethra. Spongy urethra has two parts, a short bulbous spongy urethra and a long penile spongy urethra. Now, may it be the bulbous spongy urethra or penile spongy urethra, they are in the social perineal pouch, whereas the membranous urethra is in the deep perineal pouch. Membranous urethra has to puncture the perineal membrane to enter the social perineal pouch and become the spongy urethra. So this is the deep perineal pouch, and we are having a floor of the perineal membrane here, which is also the roof of the social perineal pouch. In the social perineal pouch, you see the bulb of the penis, root of the penis, covered by bulbospongiosus muscle, having a roof of the perineal membrane. This perineal membrane is also punctured by the duct of the bulbourethral gland. The bulbourethral gland is present in the deep perineal pouch. This is the Cowper's gland, and the duct is going to puncture the perineal membrane here at the floor of the deep perineal pouch to enter the social perineal pouch so that it can enter into bulbous part of the urethra, the bulbous urethra gland of the Cowper. The gland in the deep pouch, but the duct in the social pouch. In the deep pouch, you have external urethral sphincter muscle, which is a skeletal muscle sphincter to hold the urine at our own will, controlled by the pudendal nerve for urinary continence. Males also have well-developed internal urethral sphincter to prevent the retrograde ejaculation of the semen into the bladder. Now we want to talk about some of the fascial layers in the male, and along with that we can discuss the extravasation of the urine as well. When we are looking at the anterior abdominal wall, we'll find that there are two layers of the fascia. The superficial fatty is the Camper's fascia. Deep to that is the membranous fascia of the scarpa. And the scarpa's fascia become continuous with the penile fascia, become continuous with the scrotal fascia, become continuous with the Colles fascia, which is reaching the perineal body, attaching to the perineal membrane posteriorly, which is at the floor of the deep perineal pouch. Actually, the continuity of the perineal membrane and the Colles fascia and the scrotal fascia, penile fascia, and the scarpa's fascia make it possible that the urine, which is coming out of the urethra, maybe it is a bulbous rupture of urethra, the urine will be extravasated below the perineal membrane into the social perineal pouch, into the scrotum, into the penile shaft, and also passing into the anterior abdominal wall in front of the pubic bone and deep to the scarpa's fascia. Let us look at some detailed diagrams now. It is a case of a straddle injury where somebody is riding a bike on a bumpy road and landing on the perineum, the rupture of the bulbous urethra here. In this case, as you see in the next diagram, the urine will be in the social perineal pouch, into scrotum, penile shaft, and also extending into anterior abdominal wall, as is evident here. So, rupture of the bulbous spongy urethra in a straddle injury, there will be extravasation of urine below the perineal membrane, and which is found in the social perineal pouch and into the scrotal layers, into the penile shaft, and also extending into anterior abdominal wall in front of the pubic bone, but deep to the scarpa's fascia and anterior to the external oblique muscle, anterior abdominal wall muscle attaching to pubis bone there. Now, the urine cannot enter the deep perineal pouch because it is prevented by the perineal membrane. This urine cannot enter the ictiorectal fossa, prevented by the Colles fascia. And this urine cannot enter the thigh layers, prevented by the deep fascia lata of the thigh. Now, let us look at another case of urethra rupture. Here it is a pelvic fracture leading to rupture of the membranous urethra due to pull of some puboprostatic ligament. The membranous urethra has been ruptured and the urine will be in the perivesical space around the urinary bladder, also in the retropubic space of Regius and extending into anterior abdominal wall but deep to the external oblique muscle attaching to the pubic bone. Now, this urine is remaining in the extraperitoneal space, is not going intraperitoneal because the peritoneum is intact. It will not cause any ascites. It will be extraperitoneal extravasation of the urine. It is a membranous rupture of the urethra, may be a case of pelvic fracture, as we suggested. Now, take a section of the penis to look at the buccal fascia and also the corpora cavernosa and corpora spongiosa of the penile shaft. So, here is a transverse section of the penis and we can see this is corpora cavernosa containing the blood and corpora spongiosa containing urethra carrying the urine. And outside we have the deep buccal fascia covering the corpora, three bodies there. Sometimes if there is a penile fracture, there might be injury to corpora cavernosa and bleeding occurs. Also, there can be extravasation of urine. But it will be confined to the penile shaft if provided the buccal fascia was intact. In some cases, if the buccal fascia is also ruptured, then the urine and blood can escape the penile shaft. Let us look at both the scenarios then. Here in the first case, the buccal fascia is intact. So the urine is confined to penile shaft only when there is a fracture shaft of the penis and rupture of the urethra. But in the other case, as you can see, the buccal fascia is also ruptured. So this urine extravasated from the urethra will be found in the social perineal pouch, into the scrotal layers, into the penile shaft, and also extending into anterior abdominal wall, deep to the scarpa's fascia, and in front of the external oblique muscle attaching to the bone pubis there. So these are the four places you can have extravasation of urine, as you have seen in bulbous rupture of urethra as well. But this urine cannot enter the deep perineal pouch or the ictiorectal fossa or the layers of the thigh. Here we talk about the support of the uterus, which are in addition to the muscular support. We earlier have described some good supports of uterus, that was pelvic diaphragm, urogenital diaphragm, and the perineal body. But then there are some additional supports also, like there'll be pelvic fascia condensation, which we want to talk about. Also, there is some angulation of the uterus, and that is preventing the prolapse of the uterus. That also we need to focus upon. It will be held by this round ligament of uterus, which is pulling the uterus forward, and there will be one sacro-uteral ligament which will be pulling posteriorly, so they maintain some angle which we need to discuss about. But first, let us talk about some pelvic fascia condensations. As you can see, this is the pubic bone anteriorly, this is the cervix of the uterus, and then this is the sacrum bone. From the sacrum to the uterus, you have the uterosacral ligament, a pelvic fascia condensation. Then you have this pubocervical ligament coming from pubic bone to the cervix of the uterus. Again, a pelvic fascia condensation. There's a third one which is called lateral cervical ligament of McEnroth, which will be coming from lateral pelvic wall, will be evident in the next diagram. So these three ligaments were pelvic fascia condensation, holding the uterus from prolapsing downward through the vagina outside here in the perineum. Also, you will notice that there's a round ligament of the uterus, which is a remnant of the gubernaculum, pulling the uterus anteriorly. It is working along with the uterosacral ligament, which is pulling it posteriorly to maintain some angles, and which we have to discuss now, preventing the prolapse of uterus. As you see, this is the long axis of the vagina, this is the long axis of the cervix, and between them you have 90-degree angulation. This is called as the angle of anteversion. V for version, V for the vagina. Now here you see that the body of the uterus is itself folded on the cervix of the uterus, and that is around 125 to 170 degree of folding angle, and that is called as the angle of anteflexion. Both of these are important for preventing the uterus from prolapsing through the vagina outside. In some cases, there can be retroverted uterus, and if it is so, then that will be increasing the chances of prolapse of uterus. The uterus should be kept in angle of anteversion as well as anteflexion, sitting on the fundus of the urinary bladder anteriorly. Now let us talk about those pelvic fascia condensation, the three ligaments once again. For that purpose, we have to look at the superior view of the pelvic cavity again. Anteriorly will be the pubis bone, and posteriorly will be the sacrum coccyx bone, and laterally will be the parts of the hip bone. And then we want to talk about some pelvic fascia condensations. This is a superior to inferior view of a female body, looking at a superior view of the pelvis region for pelvic fascia condensations. So as you see, there will be the uterus in the middle, and this is the cervix of the uterus, and anteriorly to the pubis bone you will have pubocervical ligament. Here are the pubocervical ligament pelvic fascia condensations. And posteriorly you will have the ligament called as the uterosacral ligament. And laterally you will have the transverse cervical ligament of the McEnroe. And they are holding the uterus in position, preventing the prolapse of the uterus. Though they are good support, but they are not as good as the muscular support. The muscular supports are the best supports, namely the pelvic diaphragm, urogenital diaphragm, and the perineal body. In addition, there can be some peritoneal folds also, working like supports of the uterus, but they are poor supports of the uterus. Like it could be broad ligament of uterus or round ligament of uterus, but they are not very good supports of uterus. In fact, they are poor supports of uterus. This is the rectum, and it will be opening as the anal canal, and between the two you will have an angle which is called as the anorectal angle. It is important to maintain to have the rectal continence and prevent defecation which is spontaneous there. Now we want to magnify this area to discuss about the anorectal ring. So this is the rectum, this is the anal canal, and the angle between them should be maintained at around 90 degree to 120 degree. As it approaches 120 degree, you will find that there is a tendency of the fecal matter from the rectum to enter the anal canal, and defecation can begin. So it is better to keep them as close as possible to 90 degree for fecal continence. For that purpose, we have several factors, and one of that is the anorectal ring contributed by this muscle called as the puborectalis muscle, making a sling around the anorectal angle. This puborectalis muscle is a part of the pubococcygeus muscle, is a part of the levator ani muscle, is a part of the pelvic diaphragm, if you remember. Now, anorectal ring is having two more contributions. In addition to puborectalis, there is internal anal sphincter fibers and external anal sphincter fibers contributing to the anorectal ring, important for fecal continence. Anal canal is around 4 centimeter long, and you can find that the lower 23 millimeter is ectodermal anal region, whereas the upper 15 millimeter is endodermal anal region. Actually, the lower part of the anal canal is coming from the proctoderm, which is the surface ectoderm, and the inner part is the endoderm part of the gut tube. This is the endo-ecto junction where you will have a dentate line or pectinate line. It is teeth-shaped line here and is the ecto-endo junction. In fact, the outer part of the anal canal is lined by the ectoderm, and it is also lined by stratified squamous epithelium. As the rule says, an external opening should be lined by surface ectoderm and the stratified squamous epithelium. But here you will find that there is one more line, which is the anocutaneous line of the Hilton, white line of the Hilton. And what is the difference between this and that is, here the stratified squamous epithelium is non-keratinized, it is wet mucosa, but below that it is true skin, having sweat gland and sebaceous gland, because the epithelium here is stratified squamous epithelium but keratinized epithelium. Now, if you look above the dentate line, there will be anal transition zone, and where you will find that columnar epithelium changing into the cuboidal epithelium is changing into the squamous epithelium, which is also called transitional epithelium. If you go still higher in the anal canal, there is a colorectal zone, and there will be only columnar epithelium. Now, this dentate line or the pectinate line is a boundary line below which you have a different neurovascular bundle, and above that there is a different neurovascular bundle. Let us talk about the differences then. Below this will be somatic nervous system, and above this is autonomic nervous system. Above this is superior rectal artery and superior rectal vein supplying, and below this is the inferior rectal artery and inferior rectal vein supplying. Above this is the deep inguinal lymphatics draining the area, and below this is the superficial inguinal lymphatics draining the area. Let us look at a similar diagram now. So as you can make out in this diagram, this is the dentate line or the pectinate line, and above that is the visceral innervation, autonomic nervous system. Below this is the somatic nervous system, the branches of pudendal nerve, like inferior rectal nerve. If we have the hemorrhoids, which are external hemorrhoids, then there will be painful bleeding because it is somatic pain, very sharp pain, carried by inferior rectal nerve, branch of the pudendal nerve. But if it is internal hemorrhoids, then it will be painless bleed because the autonomic nervous system, which is sympathetic, parasympathetic system, do not understand the pain of such nature, the pain due to the bleeding of mucosa. Now, when it comes to the arteries, it is superior rectal artery, branch of the inferior mesenteric artery, abdominal aorta. But below this, you will find there is inferior rectal artery, branch of the internal iliac artery in the pelvis region. Above this, there is the portal venous circulation because superior rectal vein drain into the inferior mesenteric vein into the portal vein. Whereas below this, you will find that the inferior rectal vein drain into internal iliac vein and towards the inferior vena cava. This is the systemic circulation, and there will be portal circulation. So there will be a portosystemic anastomosis, which we'll be looking at in detail. And when it comes to lymphatics, you'll find lymphatics above this will be draining into the internal iliac lymph node, but lymphatics below this dentate line will be draining into superficial inguinal lymph nodes. Let us look at all these things in detail now. But remember, this pectinate line or dentate line is the junction between two areas having different neurovascular bundles. Let us now start with the arterial supply of the pelvis region, as we understand that abdominal aorta will be giving some arteries to the foregut, celiac trunk, to the midgut, superior mesenteric artery, and to the hindgut, it will be inferior mesenteric artery. Since we are talking about the pelvis regions like rectum, so we need to discuss the artery of the hindgut. So let us focus upon this inferior mesenteric artery. But then you also have to talk about the abdominal aorta bifurcating into the iliac arteries, and iliac arteries giving some branches to the lower part of the rectum and anal canal. So we are going to magnify this region now. As it is evident, this is the inferior mesenteric artery, which is a branch of the abdominal aorta for the hindgut, and that is the one which is going to give us the superior rectal artery to the upper part of the rectum, a pelvic viscera. It will also supply the anal canal till the dentate line, because below the dentate line, it will be inferior rectal artery. Remember, there are three rectal arteries, superior, middle, inferior rectal arteries, and they supply the rectum, but they are also supposed to supply the anal canal. Anal canal is supplied by superior rectal artery till the dentate line, and below the dentate line, it is supplied by inferior rectal artery. So, who is giving the inferior rectal artery? Let us find out. Here you will find that there is superior, middle, inferior rectal arteries. They are also called hemorrhoidal arteries. As it is understood that when there are hemorrhoidal bleeding, there can be some arterial blood also coming from these arteries. If it is above the dentate line, the internal hemorrhoids will bleed and the blood will come from superior rectal artery. And if it is below the dentate line, the inferior hemorrhoids will bleed and it is the arterial blood of the inferior rectal artery. Though if you say hemorrhoids, it should be veins, but there is a school of thought that the hemorrhoids are actually having arterial blood as well, along with the veins. Before we talk about the veins, let us focus upon the arteries. As you will notice, we have this internal iliac artery. An internal iliac artery is giving us the middle rectal artery, and it is also giving inferior rectal artery. So, you know, the rectum is being supplied by three arteries, and we can magnify that area now. Here is the superior rectal artery, which is a branch of the inferior mesenteric artery branch of the abdominal aorta, whereas the middle rectal artery came directly from the internal iliac artery. As you talk about the inferior rectal artery, it is itself a branch of the internal perineal artery, which itself is a branch of the internal iliac artery. Let us look at all those details of the arteries now. Understand, we have three rectal arteries to supply the rectum. It is also supplying the anal canal. But be careful that middle rectal arteries supply only the rectum. It does not supply the anal canal. Anal canal is supplied only by superior rectal artery and the inferior rectal artery. If it is above the dentate line, then it is supplied by superior rectal artery, and if it is below the dentate line, then it is supplied by inferior rectal artery. The hemorrhoids which are above this line, internal hemorrhoids will have bleed, the blood coming from superior rectal artery, and below this line there are internal hemorrhoids. The bleed will be coming from the arterial blood of inferior rectal artery. To talk about the details of these arteries, let us move into the pelvis region to talk about various branches of iliac arteries. As is understood, abdominal aorta will give common iliac arteries. Common iliac artery will give the internal external iliac arteries. So this is the right-sided common iliac artery giving internal external iliac artery. External iliac artery is supposed to become the femoral artery in the thigh. Our focus remains on the internal iliac artery. Internal iliac artery gives two divisions, the posterior division and anterior division. You can remember the posterior division, three branches by the mnemonic SIL branches. In the SIL branches, the three branches of posterior division of internal iliac artery, the S is for superior gluteal artery, I is for the ilio-lumbar artery, and L is for the lateral sacral artery. Just remember three branches from the posterior division. Otherwise, all the other branches are coming from anterior division of the internal iliac artery. Now here it is supposed to supply the pelvic viscera. There are three pelvic viscera to supply, that is urinary bladder and the vesical artery, uterus, that is uterine artery, and rectum, that is rectal artery. So let us look at the branches then. You'll find that this is the superior vesical artery coming from anterior division of the internal iliac artery. Along with that, you have the inferior vesical artery as well to supply the urinary bladder. To supply the uterus, we have the uterine artery. And to supply the rectum, we have the rectal artery. Here it is called as the middle rectal artery, though there is also inferior rectal artery supplying the rectum, which itself will be a branch of internal perineal artery. Internal perineal artery is the artery of the perineum, and in the perineal canal at the lateral wall of ischiorectal fossa, will be giving inferior rectal artery to the rectum. Now we have supplied the three pelvic viscera, that is the rectum, uterus, and the urinary bladder. The anterior division of the internal iliac artery gave three more arteries to three regions. One of that we have discussed, the perineum. and the name of the artery was internal perennial artery. Number 2, medial thigh. Name of the artery is obturator artery. Number 3, gluteal region. Name of the artery is inferior gluteal artery. Remember, inferior gluteal artery come from anterior division, whereas the superior gluteal artery come from posterior division. Posterior division gives cell branches, and except all that, other branches would have come from anterior division of the internal iliac artery. So as we said, superior rectal artery is a branch of the inferior mesenteric artery, branch of the abdominal aorta, supplying till the upper anal canal, till the dentate line, pectinate line. Whereas below the dentate line, you have the inferior rectal artery, branch of the internal perennial artery, branch of the anterior division of the internal iliac artery. The veins follow the artery, so they usually have the same name. Let us look at the diagram for the veins as well. As we can understand, superior rectal artery, superior rectal vein. Middle rectal artery, middle rectal vein. Inferior rectal artery, inferior rectal vein. As you can see now, this is the dentate line or the pectinate line. It is the portosystemic anastomosis area. Above this line is the superior rectal vein, draining the anal canal. Now, the superior rectal vein drains into the inferior mesenteric vein of the hindgut, and from there it will be draining into the splenic vein, portal vein. So that is portal venous circulation. But below this line, it is the middle rectal vein and inferior rectal vein, draining into the internal iliac vein, and then common iliac vein, and then the inferior vena cava. So that will be systemic circulation. So there is a portosystemic anastomosis. Sometime due to portal hypertension, there is a reversal of blood flow, and there's a backflow of the blood which will be coming into the superior rectal vein, jumping into middle and inferior rectal vein. But these veins are thin communication. They become dilated, elongated, and tortuous. So there'll be rectal varices. If it is above the dentate line, you will say internal hemorrhoid. If you say it below the dentate line, it becomes external hemorrhoid. Internal hemorrhoids are having the bleed of superior rectal vein and superior rectal artery, whereas inferior hemorrhoids are having the bleed of inferior rectal vein and inferior rectal artery. The inferior hemorrhoids are very painful bleeds because it is somatic area, innervation, and internal hemorrhoids are painless bleed because it is autonomic nervous system supplying the area. Let us look at the details of the veins as well now. So here is the venous drainage diagram of the rectum or the pelvic viscera. Let us zoom this area here. As it is understood that there will be inferior rectal vein, middle rectal vein, and the superior rectal vein draining the rectum as well as the anal canal. The inferior rectal vein will be draining into the internal perennial vein, will be draining into the internal iliac vein. And the similar is the middle rectal vein, which drain into internal iliac vein. Then they will drain into the common iliac vein and inferior vena cava. So this will be systemic circulation. Whereas the superior rectal vein is going to drain into inferior mesenteric vein, and that's drained into portal venous circulation. So there will be a portal venous circulation and systemic venous circulation. As you see, this is going to be anastomosis, portosystemic anastomosis at the dentate line. As is understood that inferior rectal vein or middle rectal vein, they drain into internal iliac vein, which is then draining into common iliac vein, and then it is draining into inferior vena cava. So that will be systemic circulation. But when it comes to superior rectal vein, which is portal venous circulation, it will drain into the inferior mesenteric vein, which will be then draining into the splenic vein. And as the superior rectal vein drain into inferior mesenteric vein, drain into the splenic vein, it will be joined by the superior mesenteric vein, together forming the portal vein and draining into liver. So this is portal venous circulation. Now sometime there may be a portal hypertension and the blood will be reversing back. There's a reversal of blood flow into portal vein and into the splenic vein, into the inferior mesenteric vein, into the superior rectal vein, and that blood can jump from superior rectal vein into middle and inferior rectal vein, and there will be some portosystemic anastomosis. Those thin veins, which are communicative veins, will be dilated and leading to rectal varices. The internal hemorrhoids and external hemorrhoids can be bleeding above and below the dentate line. Now, when it comes to the lymphatics, it is understood that lymphatics will follow vein, will follow artery. You can also say that lymphatics will follow the artery. As you see here, this is abdominal aorta bifurcating into the common iliac artery, bifurcating into internal and external iliac artery, and the arteries are being followed by the lymphatics. External iliac artery, you have lymph node. Internal iliac artery, you have lymph node, and there is pre and para aortic lymph node. Now let us take example of the uterus here, the uterine lymphatics. Uterus is divided into three parts, that is the upper, middle, and lower uterus. Lower uterus means the cervix of uterus. Now upper uterus is draining into the pre and the para aortic lymph node. When it comes to the mid uterus, it will drain into the external iliac lymphatics there. And when it comes to the lower uterus, the cervix, it will drain almost everywhere possible. For example, cervix drain into the obturator lymph nodes, into the external iliac lymph node, into the internal iliac lymph node, into the sacral lymph node as well. But remember, cervix which drains almost everywhere do not drain into any of the inguinal lymph node, may it be superficial or deep inguinal lymph node. Then which part of the uterus is draining into inguinal lymph node? If you remember, we have discussed some part of the uterine lymphatics. Near the uterine tube will be following the round ligament of uterus through inguinal canal to reach the labia majora. From there, it will be going towards the superficial inguinal lymph node. So uterus can drain into superficial inguinal lymph node by the round ligament of uterus, but it is very few lymphatics, and that too near the territory of the uterine tube. My point is that cervix drain into almost every possible lymphatic nodes, but do not drain ever into any inguinal lymph nodes. That will help you to answer few questions coming in the exams. Now, talking about the nervous system of the pelvis region, this is the autonomic nervous system. We can talk about there is sympathetic nervous system and the parasympathetic nervous system. Sympathetic nervous system is for the storage by reducing the peristalsis. For example, this is the urinary bladder, a pelvic viscera. You want to have sympathetic storage of urine, then you reduce the peristalsis of the detrusor. For that, you can use the root value T12 plus minus 2. That means T10, 11, 12, and L1, 2. These 5 root values belong to 5 more viscera. That is the kidney, testis, ovary, uterus, uterine tube. Along with that, there is also urinary bladder. So you know 6 viscera having same root value, which is T12 plus minus 2. When you activate these root values, what happens is there is sympathetic storage by working on inferior hypogastric plexus. You can reduce the peristalsis of the detrusor and store the urine. What if you want to evacuate the urine? Then you need parasympathetic evacuation, which is nervi ergantes with root value S234. They are also called pelvic splanchnic nerve. Now they will increase the peristalsis and relax the sphincter. As the nervi ergantes are working, they increase the peristalsis of detrusor and relax the internal urethral sphincter. So urine will be evacuated. Now, if you want to stop the flow of urine, you can use the same root value as 234, but the nerve will be a somatic nerve, which is the pudendal nerve. Pudendal nerve has the same root value as the nervi ergantes, but it is working on the external urethral sphincter, which is a skeletal muscle sphincter, which can help us to hold urine at our own will. So you can stop the urine using this sphincter, the somatic nervous system, which is the pudendal nerve. Let us talk more about the pudendal nerve now. Pudendal nerve is coming from the anterior primary ramus of S234 in the pelvis region. The spinal cord number S234 will form pudendal nerve, and it will be formed in the pelvis region and leave the pelvis through greater sciatic notch in the hip bone. Then it will be hooking behind the ischial spine while being in the gluteal region. Then it will leave the gluteal region to enter the lesser sciatic notch. After that, it will be running in the pudendal canal, which is the lateral wall of the isschorectal fossa. This pudendal canal is formed in the obturator fascia on the obturator internus muscle, which is lying here on the ischium bone. So on the ischium, you have the obturator internus muscle internal to the obturator foramen, and it will be covered by obturator fascia, having a pudendal canal, having the pudendal nerve. Pudendal nerve there will be giving a branch which is called as inferior rectal nerve, which is the content of the isschorectal fossa, coming from lateral wall of isschorectal fossa towards the rectum and the anal canal. This is the one which carry pain of the external hemorrhoids. Now, this pudendal nerve is giving some branches to supply the perineum, and one of that is the dorsal nerve of the penis, and it is supplying the tip of the penis and the glans penis area. When you are working for circumcision at the tip of the penis, you can block this nerve, dorsal nerve of penis, branch of the pudendal nerve. Pudendal nerve is also giving posterior scrotal nerves in the perineum region. Let us look at the course of the parietal nerve from the posterior view of the gluteal region now. It is understood that ischial spine is a landmark where you can give parietal block. It is lying between the two notches. Above that is the greater sciatic notch and below that is the lesser sciatic notch, and as it is hooking behind the ischial spine, it is a landmark you can give the parietal block here. Let us look at the posterior view of the right gluteal region and the right parietal nerve here, passing through the greater sciatic notch towards the lesser sciatic notch. This is the piriformis muscle come from the pelvis region and insert on the tip of the greater trochanter of the bone femur of the lower limb. And there are some nerves passing above that and below that. Above that is superior gluteal nerve and artery, below that is inferior gluteal nerve and artery. Below that is also coming the sciatic nerve and comes the parietal nerve as well. So parietal nerve, which is coming from the greater sciatic notch under the piriformis muscle, will be hooking behind the ischial spine and then enter the lesser sciatic notch. Along with the parietal nerve, there are some structures called pin structures running in the greater sciatic notch and also in the lesser sciatic notch. P for the parietal nerve, I is the internal parietal artery and vein, and N is the nerve to obturator internus. So these three structures, the pin structures, are found in the greater sciatic notch, hooking behind ischial spine. They will coming to the lesser sciatic notch there. After that, parietal nerve will be entering the parietal canal along with the internal parietal vessels and giving some branches towards the lower rectum and the anal canal. Their names are inferior rectal nerve, artery, and the vein, which become content of the ischiorectal fossa, as they are given in the lateral wall of ischiorectal fossa. Now we come again to the anal canal, the dentate line, pectinate line, and we have learned almost all the details which you wanted to know. As we suggested, below this line is the somatic innervation, that is parietal nerve, inferior rectal nerve, carrying the pain of external hemorrhoids, which are very painful bleed. But above this line, it is the autonomic nervous system, could be nervi irrigantes or lumbar splenic nerve. These autonomic nerves do not understand the pain of the bleeds of the hemorrhoid, so internal hemorrhoids will be painless. The internal hemorrhoids will have blood from the superior rectal artery and superior rectal vein. Superior rectal artery is a branch of the inferior mesenteric artery, branch of the abdominal aorta, whereas the superior rectal vein drain into the inferior mesenteric vein, drain into the splenic vein and the portal vein. So there will be portal venous circulation, whereas the inferior hemorrhoids will be having the blood of the inferior rectal artery and inferior rectal vein. Now, whether you say inferior rectal artery or inferior rectal vein, they are all the vessels belonging to the internal iliac artery vein, common iliac artery vein, and then it will be draining into inferior vena cava. So, the inferior hemorrhoids or external hemorrhoids will have blood of the inferior rectal vein and the inferior rectal artery. When it comes to the lymphatic drainage, below this line it is superficial inguinal lymph nodes, and above this line it is the internal iliac lymph node, the deeper group of lymph nodes.